Okay, the task force come back to order. Surprise for you all is that we have internet back and waiting online, I believe we have Miss Davis. So Jen, if you're ready, let's go ahead and bring you in. And I will tell you that Director Johansson already spoke very highly of you and gave a good presentation, but he did so without visual aid. So whenever you're ready, come on in.
All right, can you guys hear me?
We can hear you.
Okay.
Go ahead.
All right, well, thanks for having me here. I know that I have some slides to share with you, and Director Johansson, thanks for giving an overview this morning to the committee. I will share those slides with you all here. Are you all able to see that?
Yes.
Okay. All right. So I will just go down to the slide here. I know that I want to be respectful of all of your time since you all had a bit of an overview earlier. Basically, we are focusing on the governor's roadmap that I'm sure Stefan shared a little bit about this morning, and really focusing on these particular areas that we put out last year on suicide prevention, supporting the behavioral health redesign, workforce development, and then the criminal justice reform through the diversion pilot through the Supreme Court. So as far as the behavioral health redesign, we, as you all know, invested $250,000 into supporting some capacity building training for the centers. And so we have been working with the Office of Workforce Development and Andy Somerville to get those trainings put out there. We did a survey of all of the facilities and asked them what would be some areas that they wanted to focus on as far as being ready to serve the priority populations that will be focused in behavioral health redesign. We got good feedback on that, and so those trainings will be initiated soon. The first one, I believe, will be in July, and we will be doing trauma-informed CBT training, which is a year-long commitment for the providers, but then they will be certified in the model for using that within their clinic. Also, we are working on the crisis intervention support. So we have been having a lot of conversations with Department of Health, with WAMSAC, and with WASCOP about doing some virtual platform around crisis response. WASCOP has been taking the lead on that, and will be working on putting forward an application to the Helmsley Foundation, who has very generously agreed to provide some support for Wyoming to do that over the next 3 years. So that is in motion right now, I believe. And then the last thing in this was the clinics all said that they were interested in additional supports for pediatric services because they felt like they didn't have enough expertise. And since that is going to be one of the priority populations, we looked at the opportunity to maybe utilize some funding to put a pediatric platform to make that available to the centers so that they could either use that for consultation or they could use it for direct services if they didn't have the expertise for pediatric within their facility. That is still under consideration at the moment. Next thing on there was the focus on suicide prevention. We have been doing a lot of support with the Veterans Commission for the Veterans Talking to Veterans, which is a peer support program for veterans across the state. They're trying to get veterans within each county to support this effort. And basically they become peer coaches and then they are able to support veterans within their community. Because we know what we see in the veteran community is that they're not actively seeking services through our licensed providers or through the VA. We find that it's much more successful for them to get their needs met through peer interaction. And so that is a program that we've been supporting. Department of Corrections is also offering that inside the prison. And also we have the Parks Department who has also trained a few individuals in the model that is similar to what the veterans are using, but they are using it as far as doing connections with the Park Service and mental health programming that they're doing. Then the Prosper model, which you heard already this morning from Dr. Corso, and the 5 counties that will be starting there. Also, one thing that is also in Dr. Corso's contract is to look at how do we put out a messaging campaign and either around suicide prevention, anti-stigma. What does that look like? There's been a lot of interest from the philanthropic community on participating in that. So that'll be something that we'll be looking at here in the near future of what that could look like. And that'll be a collaborative effort across the state and what we want to do to develop that. The next, as far as suicide prevention, is the Governor's Challenge. So we have been a member of the Governor's Challenge for about the last 2.5 years. That is focused on service members, veterans, and their families. This effort has been going really well. There's 3 focuses of the Governor's Challenge that the VA and SAMHSA collectively partner in this effort. The first one is to identify veterans and screen for mental health and suicidal ideation. The second group is to look at resource and referral specific to veterans. And then the third is around lethal means safety. So those are the 3 groups that have been meeting in Wyoming for some time and have really had a lot of successes in that space. That's actually why I'm in San Diego right now. I was just at the Governor's Challenge conference for innovation. Through that, we also had an effort this year to partner with the VA and SAMHSA again to be in the second cohort of developing suicide fatality review teams. So myself, Department of Health, the list is there, WASCOP, Department of Education, DFS, Coroner County Attorney, community prevention specialists, and then a gentleman with lived experience who is a survivor of a suicide attempt, are all part of that core team. We're developing a toolkit that will be available to counties throughout Wyoming if they'd like to participate. The fatality review team has already been successfully implemented in Laramie County for about the last 2.5 years. And so they are helping lead the effort with the Department of Health on this and getting this spread out across the state. There is a coroner's conference in, I think it's next week or the week after, and we will be presenting that with the Department of Health and with the coroner from Laramie County, Rebecca Reed, who is also the chair of the Coroners Association, about what this model is and find what interest there is around the state. The coroner is the essential component to that to ensure that there's the ability to review. And I think a question this morning that came up is, are we identifying all of the suicide deaths in Wyoming? And I think the answer would be no. And this is another way to hopefully generate some buy-in from the coroners about the importance of, really classifying these accurately, really with the means of being able to get good data so that we can really drive preventative efforts in an appropriate way. So be really data-driven solutions based on what we know in the counties. People participate in these reviews completely voluntarily, the family. And so there's a whole process and training that will go along with the counties who want to opt into it. The next effort is the behavioral health workforce. We are focusing a lot in this space, as many of you in the room and on the committee know. The governor put out an executive order a few months ago directing all of our licensing boards and other partners to come together. And basically, there's three priorities from the executive order. One is for all of the healthcare licensing boards to review their rules, regs, and statutes with their industry partners to identify any barriers to getting people into the workforce in a timely manner. Part of this is still in light of COVID a little bit. Some of the licensing boards adopted some of the specialty allowances during COVID for workforce. Some did not, and just really taking a good look at this again to just see, are there things that we can do that ease the burden for getting licensed, but also maintain the public safety. So the second part of that is the boards are also going to be coordinating together about looking at a comprehensive data system. We've been partnering with Utah, has done something similar to this, where the licensees, either at initial application or at renewal, will be answering some additional questions so that we can really have a better understanding of what our workforce really looks like in Wyoming. Right now, we don't have a lot of comprehensive data in this system, so we make a lot of assumptions and impacts our HPSA score.
Did we lose her? Jen, we can't hear you for some reason. We lost your voice. If any of you can read lips, tell us what she's saying. Jen, we've still lost your voice. We can't hear you. If you can hear me, Jen. Nothing there. Okay. Okay, Jen. Thank you. I think we'll move on at this point and we'll talk to you again down the road. We've had lots of IT problems here today, so we'll go ahead and move forward. If you can hear me, okay, Jen?
Yeah.
Thumbs up, okay. Okay. Thank you very much for that report, Jen. We'll hear more from you later, no doubt. You can't avoid us. Okay, we're going to go ahead and move forward on the agenda. We're going to go ahead with Mr. Laycock, who's been waiting patiently here, talking about transportation of vulnerable adults. Mr. Laycock, if you could introduce yourself and tell us everything we need to know about transportation of elderly adults.
A big ask for sure. Chairman Baldwin, thank you very much. Tom Laycock, AARP Wyoming. We're a membership organization for people age 50 and over in the state. And before I get started, I do need to conduct just a little bit of business with you, sir. For those of you who are watching, you probably know that Chairman Baldwin has had a long-standing tradition of, if your phone goes off audibly during one of his meetings, you're required to bring donuts to a subsequent meeting. My phone went off in Cheyenne. I'd like to consider my debt paid, sir.
Okay, you're off the hook.
Okay.
Debt paid. Thank you.
All right. So this conversation, go ahead and advance if you wouldn't mind, Clarissa. I apologize. We tried doing this from up here and weren't able to quite get it done. So Clarissa's nice enough to change slides for me. What we're going to go over today is just a little bit about why we're doing this. You know, we know we're getting older as a state. Well, during the last meeting, there's a little bit of questions about what that actually looks like. And then we'll move into sort of how the subcommittee actually got its start and who we are. From there, we'll go over recommendations that we put together. And for each recommendation, you'll see the continuum that we put up at the top of this particular slide. Everything from heavy lift to light impact, lower impact, to higher impact. Now, granted, who has to perform that heavy lift, is something we'll talk about as well. And then we'll talk a little bit about how older adult transportation is funded in the state right now, and open some questions. So move us forward. So we know we're getting older as a state. Between the years of 2010 and 2020, our state's population grew 2%. However, during that same period of time, our population of adults aged 60 and over grew 47%. We know that the bulk of folks who, unfortunately, more than half of people nationally between the ages of 65 and 75 don't have any retirement savings at all. This becomes your problem, for lack of a better way of saying it, because those folks who are trying to live on Social Security largely, which is an average check of about $1,800 per person per month, which, as Senator Scott likes to say, will pay for your rent, the occasional fillet of fish, and then there's not much left over. At that point, doesn't generally allow folks to pay for in-home services or things along those lines. And so at that point, the state will sort of take over through the Medicaid program. And this is everything from WICE all the way down to Community Choices waiver and things like that, because we know that the more we can keep people out of the nursing home, the less expense there is on the state. Right now, we've got 4,000 enrollees in long-term care programs. Department of Health is estimating that goes up to about 6,000 by 2040. So you saw these two slides the last time you met. Danielle Marks brought these up as APS put together a question of what do we need for vulnerable adults? How do we keep them, vulnerable adults, as well as those who are in danger of becoming vulnerable? How do we keep them out of nursing homes? Transportation is a big piece of that. And so that's part of why we're here. In fact, if you want to really blame why we're here, you can advance. You can blame Jane Carlson, who's over my shoulder here with APS. In 2021, APS put together a survey. They had a little bit of extra CARES Act money, and they were trying to figure out what's the best place to put it. Transportation came up as pretty highly ranked. She got some of us together who are already on the governor's healthcare task force and said, you know, where's a good place for this money? What can we do? They were able to find some grant opportunities for transportation specifically, but it led to us asking that question of what are we doing now as a state? What can we do better? And where are some of the gaps? And so we put together a subcommittee of the governor's healthcare task force, which you can see some of the names on here: senior centers, transportation providers, state agencies, WYDOT, Department of Health, and Department of Family Services. It's important, though, that I do mention that at no point did Department of Health or any of the other agencies actually ask us to advocate for a specific position, nor did they advocate as well. So they were great treasure trove of information and really helped out. What we've come to is senior center transportation clients generally seem pretty pleased with the service they're providing. But however, especially the off hours and on-demand services can be a little bit difficult to access. So here are three broad buckets for how adult transportation is paid for in the state of Wyoming. And I apologize, this gets really deep really quick. I had no idea how any of this worked until 2 years ago, and some might suggest I still don't.
Hold up 1 second. Go ahead. Go, Jeremy.
So Tom, I would like to just get included in this conversation as you talk about senior center clients being satisfied with the transportation. That's great if you live in a town where there's senior centers. And so the surrounding areas, you know, how far we just need to bear them back of our mind, I believe, and you can correct me on this, but we'll have the more remote communities who don't have access to any of that, except for maybe in the case where a senior center from a county seat or something does that. And I think that needs to be something that we look at as to how do we incorporate under the current funding existing structure to increase service out to those. I think the term you use is clients in that. Is that a reasonable expectation on this conversation?
Mr. Laycock.
Chairman Baldwin, Co-Chairman Larson, will absolutely have some of that in this particular presentation. One thing I've learned about this particular subject, it's elephant eating 101, right? I mean, there is no silver bullet. You try to take a little chomp out of wherever you can. But I think some of the things that we'll bring up, maybe we'll be able to help with that, because that's absolutely where we've been trying to go. One of the people that really helped us with this particular effort, her name was Jana Leinot. She's an AARP national transportation expert. Like myself, she was an old Iowa farm kid from a very rural area. Her heart's in the right place, and she really helped kind of push us through with some of this as well. So if you want to move to the next slide, we'll go very briefly over what some of these funds are. 5310 funds, and once again, this is something we just learned about a year and a half ago. This is money that gets awarded directly from the feds through WYDOT to two private nonprofits. One's called Wyoming Services for Independent Living, that deals with the west side of the state, and Wyoming Independent Living on the east. So this is interesting because they take that $350,000 per year and they write it out. It's basically a voucher program. So if you are somebody who ordinarily, some of these senior centers will request a donation, $3 or $4 per ride, something like that. They'll write a voucher for that. Or if you want to find your own driver through a program which they refer to as self-directed and keep that term in the back of your back pocket, they'll pay that driver up to 36 cents per mile for the ride. They've got about 450 people that are registered with them. You have to self-identify that you have some sort of disability that keeps you from driving, whether it's something age-related, whether it's something disabled, when you're age 18 or over. But there's a lot of options there. Generally speaking, someone who's working through Wyoming Independent Living has already found someone that can drive them, whether it be a friend, a neighbor, family member, things along those lines. So it's really a great program because when you get into self-directed, you really get rid of a lot of the strings. And we'll talk about that here in a minute. Now, moving on to 5311 funds. This is primarily where you see senior centers, university, community transportation. This is kind of where they get a lot of their funding. So about $12 million a year that comes through WYDOT and moves in that direction. In both of these cases, it appears we've pretty well tapped out the amount of funding that we can get through the feds to these two programs. The third one that I'll bring up very quickly, and this one is think buses, think vehicle. I'm sorry, sir.
Go ahead, Mr. Coach.
So on both those funds, the 5310, 5311, how is the amount that Wyoming receives determined? Do you know that?
Chairman Baldwin, Co-Chairman Larson, for 5310, the program receives federal dollars based on the state's share of population for developmental disabilities and aging individuals.
That's on the Mr. Chairman, that's on the 5310.
Correct.
So, and so give me those populations again.
Sure. Mr. Chairman, Co-Chairman Larson, based on the state's share of population for developmental disabilities and aging individuals.
So do we have a feel of what percentage of the population served of those two categories? I mean, is more than, so we have the community mental health providers, are they able to utilize those services? And again, that would probably be where you have agencies, maybe some of the independent populations, or is the majority of it for seniors?
Chairman Baldwin, Co-Chairman Larson, right now they say Wyoming Independent Living has 450 people signed up for this particular program. I don't know how much the West Side Wyoming Services for Independent Living is. In terms of are those folks using community mental health centers? They certainly could use that. Are those folks able to use this funding to get to community mental health centers? I think if they're signed up, I would think so, but I'm also a little curious, would they also fall under Medicaid state plan?
So, Mr. Chairman, I want to clarify the question. So I'm trying to, of those two populations, those with the developmental disabilities and the aging, do we have a feel of what percentage is covered by these costs? Which one are the developmentally disabled, and what percentage of them are the aged?
Chairman Baldwin, oh, I'm sorry.
Go ahead, Director.
And Mr. Chairman, Mr. Co-Chair, Mr. Laycock can correct me if I'm wrong. I'm not terribly familiar with these 5311 WYDOT funds, maybe enough to be dangerous. I think how that formula of how the funding gets allocated to states is based on shares of those two populations. I don't know if it's dictated that it's used for those populations specifically, or just assistance to transportation, rural transportation infrastructure that obviously would benefit this population. But I think it's a distribution formula that's being referred to, not a use.
So, Mr. Chairman, so Director Johansson and Mr. Laycock, so if I hear you correctly, they don't have to, they could provide rides to anyone, but the funding source is based on that formula.
Mhm.
Interesting.
Mr. Chairman, Mr. Co-Chairman, we were, before we had internet, we were going to be joined actually as well by Amy Burns with Wyoming Independent Living, who could have answered that a lot easier than I. That said, I'm happy to get it. I don't have those two, how they're specifically split up, but happy to get that
We
information.
may
for
be
you.
able to get Amy Burns at some point here because we do have Ethernet. So if she's hearing this, make yourself available. Go ahead and continue,
Sure.
Tom.
And 539 funding, that's think buses, think transportation. Can't use it for operating at all. But if you're local, senior center or transportation provider is looking for an updated shuttle bus, things along those lines. That's where this comes from. Once again, an 80-20, 80% match. For ADA, this feds will pay a little bit extra. Moving down to Title 3B. This is kind of a mix. This has federal funds, this has local matching funds, 19,000 in state general funds. And then, we talked about you will get on a bus, you drop your $3 or $4 in, that also figures into this as well. Altogether, they figured 566,000 last year of the 2.1 million that was spent on Title 3B services actually came through Title 3B. And Title 3B it's a larger pot of money with a number of other things that you can do with it. It's an Older Americans Act, federal dollars that helps with anything from maintaining healthy lifestyles to socialization. And we know that that resulted in 84,000 one-way trips in the state of Wyoming through senior centers last year.
Mr. Chairman.
Go ahead, Mr. Butcher.
And Tom, just trying to understand the structure of this. And so the local matching funds would be a required resource from, if it was the city of Lander and they had these 3B funds, they'd have to raise that however they want. And state general funds, 3.4%, which is like 50K a year. Does that come in through what agency?
Chairman Baldwin, Co-Chairman Larson, that comes through the Department of Health through the Aging Division.
Okay.
That came out to $19,000 last year from state general funds.
Say that again, it came up from?
I'm sorry, that number was of state general fund usage was $19,000.
Okay, thank you.
Mhm. Okay, now we get into Medicaid transportation options and things start to get a little hairy. So there are two basic Medicaid processes. One is state plan, and that's for medical only. The other one is community choices waiver. And once again, that's the 1915C waiver for someone who has been declared to require a nursing home level of medical need and has hit a Medicaid level of financial need. And so those are the differences between the two. State plan is medical providers only. Okay, and so now we move down to the red boxes. On the next page, I apologize for the small print. But this is, I think you'll find the Medicaid side of things, because of some of the federal strings largely, gets a little bit confusing. At least it seems to some of the providers that we've talked with. The big piece of it is, once again, there is a reimbursement rate of 26 cents per mile for someone who's acting as a transportation provider for out-of-town medical appointments. If someone's driving you in town, there's no reimbursement. Unless you're a senior center shuttle, and then it's a rate of $9.75 up to 15 miles, an additional quarter at that point.
Mr. Chairman, $9.75 per trip, not per mile.
Correct. Up to 15 miles, and after that, it's 25 cents.
Very good.
Yeah, it's 16 miles per hire. So if you're looking for someone at Kemmerer to give you a ride to a physician's office in Salt Lake, they're going to get paid 26 cents per mile from here to there.
So if I was a senior center and I had a bus and I had 10 of us on there and I was going to run you around town, they'd get $9.75 per the person, so times 10.
Chairman, co-chairman, that's correct.
Quick question. How burdensome is it to apply for the funds? If I'm giving you a ride to Salt Lake, and I'm not the senior bus, I'm Senator Baldwin giving you a ride. How burdensome is that for me to apply to get paid for that?
Chairman Baldwin, it It's not as bad if you're a friend, family member, if you're a service provider, if you're a transportation service provider, it can get a little bit wonky. We had, during one of our committee meetings, we brought on someone from the Department of Health to talking about, they would like to find more state plan transportation providers. The presentation was very nice. We had about 5 or 6 providers on who ran senior centers in the state who don't subscribe to be state plan providers yet. And they were all very polite. And then the nice person from the Department of Health signed off. And I said, so what do you think, guys? And they're like, too much administration, not enough money. Okay, it's fair. So that is sort of one area that we sort of see as a gap. So if you want to, are there any other questions on this page? Otherwise, we'll get to the black boxes, which is a little bit different too.
Questions,
Okay.
anyone? Let's go, Chair.
Thank you, Mr. Chairman. And so I think you come later on, you come up with some recommended changes, which would require us approving an increase on the per trip cost or the mileage cost, if that was something that we wanted to entertain. So
And
stay tuned, right?
Mr. Chairman,
Go ahead, Director.
if I may, Mr. Chairman, just on that note, I know we will get to it later. We are in the process, as you know, of doing the rebasing study for our DD population, our DD providers, and our comprehensive and supports waiver. As part of that, as we did in the last cycle, we combined CCW rate rebasing into that, which cascades after the rebasing. So that community choices waiver, the waiver that Mr. Laycock was referring to, that rate rebasing study is scheduled to kick off in the first part of 2025 after the DD rate rebasing is completed. So in addition to all of the other service rates that are part of the community choices waiver, transportation would be a part of that as well. And I fully agree with Mr. Laycock. We certainly have gaps. You can see it in the numbers here in terms of the utilization of non-emergency medical transportation and waiver transportation services. There's a variety of reasons for that, which we can discuss. And I'm really curious, especially for AARP's perspective, on what those demand signals are. What I struggle with is we don't have a great mechanism to see all of the transportation services that are being requested and then not able to be provided. So it's kind of a self-selection thing that if you live in an area that has it, or you know about it, or what have you, that we see the utilization data and we see the cost there. What I lack, at least analytically, is where are those demand signals of what that gap is and where are they? And maybe that's something that we can touch on in this discussion.
Very good.
Mr. Chairman, Director Johansson's.
I think that was a question too.
Yeah.
Okay. Mr. Chairman, Director Johansson, you're absolutely right. In terms of how do you find out someone wasn't able to get the service that you'd hoped? Unfortunately, most of the data that we've got is pretty anecdotal at this point. You know, a couple of years ago, the Casper's Economic Development Group was actually looking into this issue simply because from a hospital standpoint, the hospital would discharge somebody and they wouldn't leave. And it's because they couldn't find a ride. And so we're hearing a lot of those types of stories. But, you know, once again, figuring out demand and figuring out how you actually reach out to these specific people to say good, bad, you know, somewhere in between, no. I did also speak with our friend, Ms. Carlson behind us, who said that they were talking about putting out another similar survey in the coming year as well. So hopefully that gives us a little bit of information. But yeah, the cause and effect person, like myself, also has that question of I think we're doing pretty well, but you know, it's tough to justify exactly where we're missing. So the black boxes that you see, this is once again the community choices waiver. So this is the 1915. See a lot of different processes from the original state plan. In essence, we're trying to keep people in the home as long as we can. And this means getting them to the grocery store. This means getting them, you know, socialization, things along those lines, the pharmacy, whatnot. And so really the process is pretty cool in a lot of ways. You've got the waiver recipient who works with their case manager to talk about what do you do? What do you need? Then they put together, you know, kind of a course of treatment. How many units do you need? How many miles? How far do you need to go? But there is a capitated budget for that. Once again, the cost for doing this, so you're getting $80 per month for transportation. Each one-way ride is reimbursed at $6.20 for a ride that doesn't require wheelchair access, or $9.75 for one that does. And once you get approved, you get a prior authorization number. Now, if you're someone who's pretty good with being able to say, I like to go to the grocery store on Wednesdays, you can find that provider, you can find that transportation provider and get a prior authorization number that's just good for every Wednesday. If the change is needed, generally speaking, it's 24 hours or more that they like to get for the notice so that they can send a prior authorization out at that point. If you'd like to be a provider, a driver, there is a process by which you can take a YDOT class, submit to a vehicle inspection. So the senior centers have a tendency to do that through the aging division, and that allows them to apply for Title IIIB funding that we talked about earlier. So any questions on that piece?
Go ahead and proceed.
There does appear to be one last thing, a scenario by which theoretically an umbrella organization, perhaps a senior center, could hire out local providers, citizens at large, because that's one of the questions that we're looking for, right? If you've got that scenario by which Co-Chairman Larson was discussing, where you're outside the realm of where a senior center actually has a established route, what could we do to try to increase available rides? And that's something that we kicked around just a little bit, is could you have let the senior center go through the process of vehicle inspection, YDOT class, et cetera, and perhaps use citizens at large to go ahead and register, act as transportation providers without having to necessarily register as Medicaid providers specifically. So it's something we discussed, and maybe there's something there. We'll see. So moving forward, we'll get into some of the recommendations that we put together. The first one, good news, this one is pretty easy. So of the big black boxes you just saw, through the Community Choices waiver, we talked about that term self-directed care, right? And that's where the client for Community Choices actually acts as sort of the hiring entity. Okay. And so what that means is, instead of having to make several calls to find your own provider, you can then hire someone. So if Chairman Baldwin decides that he's not in a place where he wants to drive anymore, but his buddy Co-Chairman Larson would be happy to drive him all over the place, he could then hire Co-Chairman Larson at the same rate to feel free to go ahead and drive him around without having to go through the YDOT class, without having to go through the registering as a CCW provider, things along those lines. So it takes a bunch of those black boxes that we just saw and sort of takes them out of the realm.
Mr. Chairman.
Go ahead, Mr. Co-Chair.
So then Tom, he hires and then he gets reimbursed for his expenditure, or does the person driving how does that work?
I believe that goes to the person driving.
So it's the person driving that submits the bill for payment.
Well, I believe Chairman Baldwin in this instance would have to submit the justification that he took the ride, that they went somewhere that needed to go, and then submits for reimbursement.
Okay.
Mr. Chairman, if it would be helpful, I think there's some nuance in these scenarios, because self-direction is something that's growing in the waiver service areas. So not just for transportation, but other types of services where participant self-direction is exactly how Mr. Laycock described it. Rather than speak out of both sides of my mouth, we'd be happy to kind of prepare a flow chart of how that works for the committee, especially when it comes to transportation reimbursement. Frankly, I'm not sure if in that scenario, if you as the driver would receive direct reimbursement, or if Chairman Baldwin would, and then would presumably give you a cut of that or all of it. So we can certainly, I just don't know off the top of my head how that flow works.
Thank you.
Mhm. So, Mr. Chairman, where this really improves service is all of a sudden in an area where there's not a senior center shuttle around. You can then hire friend, family, somebody close who's willing to make those drives. So it increases the number of available service providers pretty quickly. Once again, you'd still be stuck at your $80 per transportation per month. That wouldn't change. Now, with more available usage, theoretically, you could end up having a higher bill or more people using this service. In terms of how it's going to be done, this can be done through a state Medicaid plan. Now, having been around our friends at the Department of Health for quite a while, it always seems to feel better when you've got a policy high five from the legislature saying, hey, this seems like a really good idea. So I'm not sure whether, I don't think that's a bill by any stretch of the imagination, but I think any encouragement in that direction would probably be appreciated.
Policy high five. Go ahead, Mr. Co-Chair.
And I apologize that I'm so slow on the uptake on this, and this is for you or Director Johansson, either one. So if I lived in a rural community where there was none of this and I wanted to use Fred, do I need to call ahead of time and get authorization for that? Or how, just remind me how that works.
Mr. Chairman, and we'll include some of this in the
Okay.
explanation I just mentioned, but when a waiver participant goes in a self-direction route, there's kind of a different process of how, quote unquote, provider gets hired and paid, but we'll try to illuminate all of that in the materials we'll share.
Okay. Proceed.
So, Mr. Chairman, the next one, in this one, once again, heavy lift, but could have a high impact. And something our providers told us a few different times is if we could simplify the Medicaid process, less onerous in terms of administrative issues, helping out with, a little bit on the transportation side, it would be helpful. And some of that, I think, is a matter of, some new providers in terms of their, coming on board, as well as, as you saw, there's a lot of boxes there. There's a lot of hoops to jump through. I don't know whether that means a committee like ours and gets together with more Department of Health things, or whether it's an issue where there's some consultancy needed. So I'm not entirely sure where that lives, but that was something that was brought up a number of times in my notes in our meetings.
Mr. Co-Chair.
And this would be in your rebasing study, Director Johansson?
Mr. Chairman, yes, I think in part.
The next one down is headstrong into that rebasing study. And this goes back to that conversation we had where, our Medicaid providers or our transportation providers said the Medicaid process is too onerous and doesn't pay enough for us to want to really jump into it. So one thing that we were able to dig into, I mentioned Jana Leinot a little while ago. She was able to walk through with us. Now there's no real list of here's what every state pays for its Medicaid rides. But if you go into old US DOT presentations, you're able to kind of track down and there's a little spot in some of them that says, what do you pay for Medicaid transportation state plan, as well as 1915C waiver. I was able to see about 20 of those, and the lowest number I was able to find per state ride was $16 per ride. That was Texas, and it was 10 years ago. So I'm not sure kind of where that lives. So we do think the rate rebase process in early 2025 is a great idea. I was a part of the rate rebase for long-term care and nursing home. That was a fascinating process. It was very in-depth. So we're pretty excited to see what that looks like. But the heavy lift, unfortunately, on that end is yours, because most likely it would be the Department of Health coming and saying, here's what the numbers are, and here's why we think a rate would be justified in increasing. The other way you can do it is if you wanted to try to put money directly into the state budget and then ask for the department to come back with an exception request and justification with trend data. I think ordinarily speaking, the rate rebase seems like the most straightforward process, and the one that we've been used to over the course of a number of years. This might also allow for the opportunity to discuss that PACE Light proposal that was made during the Labor Health Committee meeting in Saratoga last year. If you remember that, the PACE study a couple of years ago, once again said PACE was probably a little more onerous than people wanted to be a part of. However, the patient satisfaction scores were through the roof. And so what were the components that really jumped out? And it was the bundling of adult day, which we have 10 in the state right now, as with transportation. And once again, that would go under the CCW, the Community Choices Waiver. And so we'd end up spending more on community choices. But the question is, with that spend, are we able to keep people out of the nursing home even longer than we would be otherwise? And so this might be a good time to consider that as well as we're looking at the transportation study. The next one that we run through, and this is a little bit fascinating. So in 2022, our friends at 211 actually won a competitive grant from the United Way. They got $13,000 plus $2,000 administrative funds. And the thought was to use this in some of your larger cities that have Lyft, specifically Lyft. And for folks who don't, older adults who may not be in a place where they feel comfortable using Lyft on their phone, they could call 211 and 211 would then arrange for a Lyft. The good news is over 900 rides, and they found out that older adults like going to the grocery store, the pharmacy, and the liquor store. That one kind of stood out a little bit. But what they found out also was that was a really time-intensive thing to do, to be on the phone a couple different times trying to get a Lyft ride for somebody. So the good news is we have an in with Lyft. 211 has said, we'd like to do that again, but the process was onerous. We need to figure out a better way to do it and more people to help us do it. The other good news is that 211 has offered to make that connection to us for 211 if we can find other areas where Lyft may work. Now, once again, that may not be a great option outside of your more urban areas, or theoretically, maybe you could do some recruiting to be a Lyft driver if there's that opportunity too. Now, interestingly enough, Uber Medical and Lyft are now doing Medicaid rides in various states. Through that process, I got, through our national office, I got some contacts with the Lyft medical folks just this last week, and we'll have them, every time it's a good idea, that flashes. That's my theory. But we, every time, so we'll be talking with those folks. We'd love to have Lee and Elizabeth on. We don't know if it's a thing. Maybe it's a thing, maybe not, but it seems, they're in 21 states. Maybe there's some reason for that. The next one, the regionalization efforts. Now, interestingly enough, these next two really come from the transportation providers themselves. There's been conversation around this idea that we do pretty well in our own communities, but is there a chance to maybe expand how we look at these things in more of a regional effort? And we're going to have a provider on Zoom as well for this one. The example that was given to me was, if you're in Buffalo, they do trips to Sheridan and they do trips to Gillette about once a week. If you're going in and you're doing an outpatient procedure, you can get a ride there, but you're either stuck for 2 or 3 days, or you need to find your own ride. And that's the question: is, does this make sense as we're having this conversation to try to find a regionalized approach, which the way it was described to me was very interesting, almost like the governor's EMS regionalization pilot idea. Could we use that with similar regional coordinators to put together rideshare software that allows for someone the next time Gillette's coming to Buffalo or Sheridan to be able to use that and coordinate a little bit better? So that's something that's probably a little ways off, but as we're having these conversations, it's something that the locals felt was important. And then the last thing that we brought up, volunteer ride programming. So the members of our committee have really been interested in finding a way that we can offer volunteer rides, not to take over nursing home stuff whatsoever, but this is sort of those one-offs. This is, you go to a doctor's appointment after hours, things along those lines. You need to go somewhere now instead of tomorrow, things along those lines. And so some of the big barriers that we saw was the biggest barrier to any volunteer ride program is that volunteers are scared to death about what this is going to do to their liability insurance if they're volunteering. That's where a lot of conversations end. We had a good conversation started in Casper with this, and it kind of got shot down in a hurry. I do mention up there a number of other states have passed a law that says a volunteer's auto insurance cannot be raised substantially solely on the basis of volunteer service. That does exist. We have the model language. Had a very brief conversation with representatives from the insurance lobby last year. They did not seem opposed when we brought this back to some of our volunteers. the answer was, okay, what's it mean? How do you prove that they didn't raise it substantially solely on the basis of volunteer service? So there's a little bit of back and forth within that too. The other conversations we've had around volunteer rideshare programs is the question of, could we take advantage of the Governmental Claims Act by having a governmental entity run a rideshare program? We've got a few people that are working on that. Seems like a bit of a long shot, but worth discussing.
So, and maybe when our insurance folks are on, they could answer this, but I'm not sure I'm understanding if I mean, I volunteer to take somebody home from church. I don't have to report that I'm volunteering that to my insurance company. I'm trying to make that connection. Is there a requirement that insurance requirements are different if you're providing rides for somebody? Where is this? I'm trying to figure out how this surfaces and becomes an issue. Because I think as long as you're, or is it, so is the volunteer getting paid? Is volunteer not, I'm just not sure that I'm tracking why the insurance company would care if you get to choose who rides in your car, right?
Mm-hmm. Chairman
Go ahead.
Baldwin, Co-Chairman Larson, I don't know that I have the answer to that. I just know the issue of liability amongst volunteers is the thing that tends to shoot these things down in a hurry.
But
But what is the liability that you're concerned? I think I don't know specifically if you have to report it. I know I have to report using my own vehicle for work, but I don't know that I've looked in deeply enough to know if I have to report for volunteering.
so, Mr. Chairman, I guess I haul my son and his buddies to, a baseball game, or Kip, do you have some?
Oh.
It's a matter of, you can have a volunteer employee, and that's what these are. They're not gonna be paid, but they're still having to go through a screening check, training, all that stuff. So you can't, if you're doing work in your vehicle, transporting people for work, then that's where your risk comes. If you're just a good neighbor, following your friends around, whatever,
Okay,
that's not the issue. The issue is when you do it for employment purposes, whether you're paid or not.
okay, follow up.
Go ahead.
So did you sleep at Holiday Inn Express? Did you sleep at Holiday Inn Express? You've done it all, Kip.
That's right.
Okay, good, Mr. Laycock.
That makes sense.
Yeah. Mr. Chairman, the last thing I was just going to mention is there is rideshare technology. We've actually had presentations from a number of dispatch softwares that do allow for, setting up volunteers and such programs. ITN specifically, ITN Country has one that seems to be low cost, but by the same token also allows for various nuance. For example, one of their programs allows that if you, let's say you're in a place where you're fine to drive now, you've got time, you'd like to be a volunteer, you can log your volunteer hours in their system and then later receive those volunteer hours, those volunteer rides back. We've seen programs as well that do things like you've stopped driving, you've got the car in the driveway, you can donate the car in the driveway, and that then goes against sort of an allowance that you have for volunteer rides later. So this world is sort of fascinating. What we're finding is we need someone to help us in terms of actually running something like that. But everyone that we've talked to thinks that there needs to be some component of volunteer rideshare. Okay, and the last slide that I've got, and I thank you for your attention. Other things that our transportation subcommittee is looking at, we talked about that program coordinator for volunteer. Could that be a Vista volunteer? We don't know. We're kind of diving into that a little bit. The Wyoming independent living that we talked about, the 5310 funds, it seems to be a very easy to use type of program. Not a lot of strings. Could we, send money in that direction? Right now, they're pretty tapped out in terms of capacity, in terms of people. But could that offer some modeling for the future. And in fact, 5311 funding is something that you can match as a state. We talked to our friends in Kansas, and they talked about the state of Kansas does a match for 5311 funding. I mentioned the Lyft, Uber, and medical, as well as the ITN. The last thing I'll mention is Cheyenne Regional Medical Center has been, they're in the early stages of an EMS grant, basically to try to get people to and from doctor's appointments. They're picking up, dropping off, and then doing some work around, seeing some of the frequent flyers from time to time without taking the fire truck, without taking the ambulance, just doing a check on someone there. The demand has been far more than they would have thought at this point. And so the question is, how are they going to sort of define success, and what lessons can we take from there? So we're still going to meet, we're still going to talk. But all that said, I threw a lot at you, and I'm sorry for getting a little bit into the weeds in a hurry. Is there anything else you'd like us to bring, or is there anything that you see as having potential?
Any questions, answers? Go ahead.
So I would just like to know if you've got any immediate action items you think that we should be working on. You talked about these recommendations, then said you're going to follow up with some of that. Is there anything that's ready now for that we could be looking into or pushing onto a standing committee or?
Mr. Chairman, Mr. Co-Chairman, the self-directed vote of confidence, I think would be a great thing. I think the transportation rebasing is important in terms of things for today. I don't know that I've got anything really amazing for you in terms of what.
Follow up. Stefan.
Follow up. Oh, go ahead, Director.
Thank you, Mr. Chairman. I promise I'll be brief, but just a few comments. First of all, I appreciate the work that's gone on over the past several months, developing some of these recommendations, which I agree are absolutely worth digging into. I think in the short and intermediate term, Mr. Laycock's recommendations are spot on, that we should focus more on building out self-directed care, and transportation is a big part of that, because I think we can find efficiencies in how members locate access to a service like a ride or transportation. And in the intermediate term, I know it's a little bit further out than I think folks might like, but that rebasing study for community choices waiver writ large, I think will provide good information to our decision makers and appropriators on where those gaps are and what might need to be required. Because if you think about it, what we're really trying to do is we're trying to put our thumb on the scale of supply. And there's several different access issues, transportation being one of them, where providers or potential providers make calculus, I would assume, on a few different factors. One being, how much am I going to get paid for this? And based on that, is it worth going through this process to enroll as a provider? Now, I have to pause there and mention, because it's the legislature should take credit for this. A lot of our provider enrollment process is much simpler now than it was several years ago, because of the investment that you all made in our WINGS technology infrastructure. So in general, provider enrollment we process everything in about 11 hours, as opposed to, months in some insurance plans or in Medicaid programs. So I think there is some communication and awareness that we can make it at least known that the process is not as scary to go through provider enrollment, and not as cumbersome as maybe some think off the cuff. But on the other side of that coin, you are becoming a Medicaid provider, and that's a real thing. And especially under the waivers, there's different provisions and things that have to be guaranteed, and process and bureaucracy that you have to go through. So those are areas where I think we can find some pain points and maybe work together to try to tweak those to try to get better supply of transportation. And finally, when it comes to rideshare apps, I'm fascinated by that idea. I know 3 or 4 years ago, we had discussions with Uber and with Lyft, who were starting to pursue, entrance into the Medicaid world for, Medicaid populations. The challenge then was very similar to why you don't see a lot of deep managed care networks in Wyoming and healthcare, is because there just aren't big networks here. And so what we found then outside of Cheyenne and Casper, very difficult in terms of how do you scale that, what's in it for those companies, is going back to what's the rate that would be paid, what's the budget, et cetera. So I think some of Tom's suggestions of how do you mimic that sort of rideshare concept where there's more on-demand availability of transportation service, especially in our more rural areas, might bear more fruit than let's see if we can get, Uber or Lyft into some of these more or less populated areas. Not saying it's impossible, because I think that driver recruitment could absolutely happen, if the rates were right. But whether the companies would be interested in developing their networks there is kind of a different story. So with that, I'm certainly happy to answer any questions that the task force has regarding, Medicaid or waiver process, few follow-ups that we have for the task force. But Tom, just appreciate the information.
Thank you.
Go ahead. Okay.
So I appreciate both of those comments, and I would just refer the task force to the document that Department of Health and DFS put together, kind of outlining what essential services we really need to have across the state. And transportation fits into that. And so in my mind, I'm looking at remote areas. So if you're in DuBois, and there's not an Uber, how do I get to Riverton or to Casper or over the hill to Jackson for a doctor's appointment? And so could we, as we look at this, in thinking of opportunities for people in those rural communities, if they were willing to use their own vehicles to provide those rides, then could we, of course, make it worth their while on reimbursement? But if there was requirements then on insurance that we do, like in DEQ, as you put up bonding for some of these things, they reimburse you for the bonding. Maybe we reimburse them for the increase in their insurance if they can validate that, and they do. I mean, there'd be some criteria, but I'm just trying to think how in these rural communities that we provide a network as limited as it may be that allows our seniors to be able to get to services that they need in other communities. And I think that this conversation is a healthy one, and I just throw that out there as an idea to pick somebody's brains, Director Johansson.
Mr. Chairman, Co-Chairman Larson, I don't want to get too conceptual or philosophical because I agree with you on that front. I think in addition to that, I may be wrong here, but I assume that informal networks of transportation happen. And it goes back to that demand signal thing I mentioned before. We don't know the extent that folks are either not getting a service, not going to an appointment, not going to the grocery store. We just don't have an information channel that's coming back to us saying, what's that volume? And I don't think we'll get there. It's not something to build. But, I think there's probably a percentage of that gets figured out through friends, neighbors, family, et cetera. And so in addition to all of these policy mechanisms or financial mechanisms we have, and I'd be curious for Director Schmidt's thought here too, because she mentions, kind of this aspect of community a lot. Encouraging, spurring, growing a sense, especially in our smaller and rural areas, that there is this population out there that could benefit from, a neighborhood service and it's not even a service in quotes, but helping out your neighbor. You've got someone who's elderly or disabled living nearby that needs to go to Gillette every couple of months or what have you. How can we get some awareness out there that there's potentially a need, that we need some more, neighborly and friendly participation in folks' care. And then on the back end of that, if we could have, these participant self-directed reimbursement options that sweeten the deal a little bit, that would be great. But I think there's something with public awareness or what have you, if we could try to encourage that type of informal network, to your point, Co-Chairman Larson, of, well, I take someone to and from church or to and from the grocery store. It just happens. And we know it happens naturally, but how could the state, how could the departments or the associations message that there's a need there? I do think not dollars and cents, not, policy per se, but there's potentially a role of the state just to make our public aware of that issue so that maybe we see some more encouragement to help those folks.
let me throw one more thing on top of this here, and then we'll get to your permission. And I'm always thinking upstream, like I talked about this morning, and I know the director's aware of this, the RPM, remote patient management, which is something I just discussed yesterday. We may be able to reduce the number of times that these people need to go to the doctor, need to go to wherever, hospital, by giving them a pulse oximeter at home, by giving them a blood pressure monitor, connecting with the app to then send that to the provider's office. And so it's thinking upstream, and it's the way we can tie this in. And I think that's a big connection we need to build. Go ahead.
Well, and Mr. Chairman, real quick to that point, during the pandemic with some of the dollars that fell out of the sky, in Medicaid, we did a big remote patient monitoring push that was, I think, pretty successful in that a doctor or provider could have that connection with a patient or a member that likely prevented many trips to the office, and telehealth's a big part of that. But again, going back to awareness, that is something that, as a Medicaid agency, we have the capacity to do it. It does come down to, what devices do you order? How does it get distributed? How does it get paid, et cetera. But your point's very well taken, because I do think there's inefficiencies in, no offense to our medical providers, in needing to go to the medical provider's office when certain things can be handled remotely.
I just sat in my office, just to throw this out there yesterday. I just had a presentation on this yesterday because we got some new approval through the AT&T program to do these things. We sat right there with two providers and went through a list, and we came up with dozens of names of people that we can, instead of having to come and see me every 3 or 4 weeks, they can come see me every 6 months maybe. And it's simply by this remote monitoring, by a remote app. And it's huge. It's a big deal. Anyway, go ahead, Director Schmidt.
Thank you, Mr. Chairman. And since the director gave me an open door to walk through, I'm going to walk through it. And that's in regard to community. And I think it was Megan earlier today who spoke to this idea about we have resources. We just don't have a lot of connections to those resources. And as I sit and think about the role of community, certainly there's a huge role for the church. We hear that a lot during conversations about that willingness and desire to serve and help. I think what is missing, though, are those connections. And I think about that from our agency's perspective. We know a lot about the families in need. And informally, in almost every community I've been to, there is some sort of informal connection between our office and a church, or our office and a service organization. But when you're talking about deploying some sort of response like transportation through systems like that, I do think we need to be mindful of the role of the state in that. Can the state help provide some infrastructure, whether that be in, funding for an application, an IT app, which, a senior center or somebody who's a locus of that information could connect and serve as that point to those volunteer organizations that say, every Sunday, I just want to help. I want to be on call to go help, or probably better choice, Tuesday. So if somebody wants to go to the grocery store, somebody needs to go to a doctor's office, that senior center who's hopefully engaging with elderly around the community knows that, can make that connection. But those demand signals, as the director pointed out, are incredibly difficult to figure out unless there's somebody tasked with paying attention to those demand signals. And that might be something then that gets at the rideshare, gets at all of these other things without having a full-blown investment of some sort of fleet of vehicles.
So I would just completely agree that I think we could do a better job communicating with the communities on ways and opportunities to serve our fellow men, right? But here's the challenge we also have, and at our own demise, is I think that there's, for those who've been around a little while, there's sometimes can be a reluctance that there's a neighbor down the street that needs to run to Casper to get some help, and I think I should do that. I have the means to do that. I've got the time to do that. But if I wreck and she's injured, their family's going to sue me. And the thought, so then you have to say, okay, I got to take care of Becky. I don't want to lose those assets that we put together. I did And so I think that there's that scenario that I think is putting some restrictions on people making those volunteer efforts, particularly more as there's miles involved. So trying to connect from rural communities to get services in the larger communities. And I think if we can somehow address and put to rest the ability to protect against those concerns that might arise. And it's no different than you'll recall, and we smile about taking care of the DD population. Well, that's really just a job of the church, right? And as neighbors, we should take care and give respite care. But there's real concerns if the good person we're taking care of chokes on something at while you're providing respite care at his house, then you've just opened yourself up for this huge liability, which is we hear from our providers, this whole insurance idea. So there's, as much as that may have been the way of life when Waltons were on the farm, that we're no longer there. And I think that there's still a strong community desire to serve and to help their neighbors and to help those who are less fortunate. But I also think that there's some restrictions that are in place that if we could somehow figure out how to relieve the concerns that those bring on, that we could enhance. Does that make sense? Thank you, Mr. Chairman.
Well spoken. Further committee. Questions, answers? Mr. Laycock, answers.
Mr. Chairman, one thing when Director Johansson was talking about increasing supply for transportation providers, one thing kind of, rattled around my brain a little bit. Allen County, Kansas is a county that we had talked about because they seem to be fairly well. They've done a nice job with their transportation. It's just a small county. It's what are you looking at? Like 10,000 people total. But one thing that they talked about that sort of, made a difference here was they talked about the state of Kansas actually uses a program by which I can sign up to become a transportation provider through their Medicaid program. And then it almost becomes like the state's own Uber. So I can then click on my phone to take rides, not having to go through a rideshare program itself. And so in other words, I can take any of you somewhere and get paid to do it through this particular program that has a $200 per month licensing fee. So if you're looking to increase supply in areas where maybe an Uber or Lyft isn't going to exist, it's a bit of a moonshot, but in theory, you could go down that route as well. And we'd be happy to dig into that and what that means if there's interest.
Any questions, comments? Very good. Thank you much. And thank you very much for the donuts. It didn't gain you any extra points, but thank you.
That worked.
Yeah.
Thank you.
Good hard work. Okay, committee, that brings us to the next item. Yeah, I'll eat those if they're sitting there. Brings us to the next item, talking about proposed essential services. Oh, wait a second, we have a hand raised from LSO. Oh. See, you keep us online. Let's go. I presume we must have somebody. Do we have anybody in the audience here who wishes to comment? See, no one. Anyone online? Okay, but it was a good point nonetheless. That takes us to the next thing. Proposed essential services for vulnerable adults prepared for this task force by the Department of Family Services. So we will turn to Director Schmidt if she'd like to walk us through this.
Sure. Thank you, Mr. Chairman. And this was a combined effort with the Department of Health as well.
So, Mr. Chairman, with your permission, I would ask those members of the task force and those here that are watching, the reason for this is I think as we try to develop our policy, we need to be ready to vote it, maybe not in this meeting, but in Torrington. Do we agree that this is the list of essential services so that we can develop that policy moving forward? So please pay attention to this and consider how we make this work, expand it or retract it. But I think that we need to be recommending a policy regarding what essential services are. And so would just preface the good work that DFS and Department of Health have done in getting this ready. Thank you, Mr. Chairman.
Yes, thank you, Mr. Chairman, and thank you, Mr. Co-Chairman. Yes, this is, if you recall the last meeting that we had, there was a presentation of a massive spreadsheet that tried to capture across the state what's available for people who are vulnerable. So that includes younger people who are maybe have a dual diagnosis or intellectual disability of some sort, all the way up to those that are elderly and anyone in between that meets that definition. And so that was the start of the conversation that sets the tone for what are we buying? What is out there? But out of all of that, we've never as a state had a serious conversation about, okay, all of that is out there, but what of it is essential? And what is the state's role in making decisions, whether those be policy decisions or financial decisions around those services for people who are vulnerable in any given community? And to go to the co-chairman's comment, the question really is what if we have a vulnerable adult in Farson? What is it that that person should have available to his or herself in order for either the agencies to assist with that vulnerability and hopefully either avoid a crisis or decrease the time that person is in crisis, or getting that person to somewhere where they can then get the services that they need? As was stated by Mr. Laycock, and as we've discussed before, this is a growing population for Wyoming. And it is a tricky population because the difference between an adult population that we serve and a children's population we serve is one primarily around rights. Adults have the rights to make decisions, and adults have the rights to make bad decisions. And sometimes we're uncomfortable with those decisions, but at the end of the day, those are rights. However, we also know, though, that without some level of prevention or intervention, those adults can get to a place then where they don't have any ability to make their own choices, to make their own decisions. So it's a fine line around essential benefits and really those people who are vulnerable and really need a lot of assistance. So as we walked through this, there has to be some sort of target population. So, the definition of a vulnerable adult is, we have a very specific definition, but I think in the community, we don't necessarily stay in tune to that specific statutory definition. Instead, it's someone who we believe needs help, somebody who is maybe homebound, doesn't have transportation to the grocery store or a medical appointment. And then the Department of Family Services receives those calls. You need to go do something. So we make some decisions about what that something is. But where we establish kind of the target for this conversation is if it's serious enough that DFS opens a case. So we go through a series of questions or some screenings that say, does this really meet the DFS definition of opening a case, which we can do as a prevention or assessment case? Or if we're very concerned and there's reason to believe there's abuse and neglect or exploitation, we'll investigate, which is a little bit more serious, more defined. So for the purposes of this conversation, we said, okay, it's anybody with an open case, because what that does is it gives us permission to kind of assist and use our resources. And then in conversation with the Department of Health and also to the studies or the surveys that Mr. Laycock mentioned, certainly according to the conversations we have with our own staff, what are those essential services? So if you flip to page 2 of the handout, you'll see table 1, which is the essential services matrix. And this is what we are proposing as a discussion point for those essential services. So first, safe housing. And housing is a big, broad topic in question. For us as an agency, what safe housing means, it could be temporary, it could be long-term, but it's somewhere safe for that adult to be while we're able to help connect to other resources. Sometimes it's until we can get a Medicaid application and a medical determination for placement in some sort of skilled nursing facility or assisted living facility. Other times it may be a hotel for a few nights as we go in and are able to maybe clean up a home.
Mr. Chairman.
Would it also include their ability to stay in their own home if they just had the resources for one of the programs to pay utilities or to winterize, or does that fit into that housing as well?
Absolutely. Safe housing. Utilities are a big part of safe housing, weather
So-
station.
Mr. Chairman, so as you mentioned, it covers the horizon from your own home clear over to temporary or even into long-term care.
Yes, Mr. Chairman, Mr. Co-Chairman, that's correct. The next is food. I mean, these are all very familiar, a little bit like Maslow's hierarchy of needs. We need to eat. And so food can come in a variety of sources for people who are vulnerable. It can come in the form of a benefit such as SNAP. It can come in the form of Meals on Wheels through a senior citizen center. It can come a variety of ways, but what we know from a well-being perspective, medically as well, is that nutritious food is essential to for everything else to be able to take hold. So food being a big part of the conversation. Medical care.
Again,
Mr. Chairman, go ahead.
And so this is not an exclusive list. So again, there's flexibility there because you may find an emergency where they need food now. They haven't eaten for 3 or 4 days. We need food now. Can't wait for a food box or SNAP process. Correct?
Mr. Chairman, Mr. Co-Chairman, yes, and that is where we rely heavily on our food insecurity network, our food pantries, our food banks, churches who provide those resources immediately,
If they're there.
if they're there. Yes.
Right? And if they're not,
And Mr. Chairman, and Mr. Co-Chairman, if they're not, then DFS has a little pocket of money. Let me emphasize a little.
there, and I wanted to push you down that rabbit hole, Director Schmidt, because that's what we're saying, that even in these remote towns, these rural towns, there may not be any of that, and we still need to be able to provide food's an essential service. And so we've got to have the means or the capacity to provide even in those situations, if this is an essential service.
Yes, Mr. Co-Chairman and Mr. Chairman, Mr. Co-Chairman. I think one of the big conversations for this group is really what are the essential services, and then what's the best way to provide those essential services? And I think that's going to be a big part of the debate. Certainly state agencies can step into those voids. We have the infrastructure to do it. Is that the most appropriate place? Maybe for some services, but maybe not some others. I will continue to push the idea of community and the role of community, because as we know, communities are very unique and they solve their problems in their own ways. But sometimes they just need a little bit of financial support or maybe some agency support to help them there.
Mr. Chairman,
Go ahead, sir.
so then as we bat this back and forth across the net, I think then what we're saying is, as we discuss what these essential services is, as we provide them, what's the role of the state in providing them? And these warrant further refinement or definition to where we understand what that policy is. This is not a completed effort.
Mr. Chairman, Mr. Co-Chairman, I think this is the beginning of a really good conversation.
Thank you.
And I do a little bit of editorial comment. I met with our local DFS staff yesterday, and the conversation adult protective services comes up. And I'm always reminded of the lack of structure around adult protective services. So in our child serving area, we have federal law, we have state law that prescribes what we're going to do, who's going to provide it, and how that's going to get funded. We lack that basic structure when it comes to adult protective services. So I'm very excited for this conversation because I think it gives all of us a little bit of a firmer understanding of, one, what's the state's responsibility in this, and then how did the agencies actually get in and support it. Right now, we're all things to all people in this world, and that sometimes is a little bit tricky to manage. Okay, moving on, medical care, I think that goes without saying. That comes in a variety of different ways. As the chairman just mentioned, it can be remote, it can be direct, but at the end of the day, it's that service provision to that person. Again, using the Farson example, if that individual doesn't have access to some sort of remote system to allow that remote check-in, then there has to be some other way to get that person to that medical care virtually or physically. And again, that takes infrastructure and coordination. Transportation, I think we covered that well enough with Mr. Laycock and lots of good conversation there. The last two, case management and someone who cares. What our agency does in regard to vulnerable adults is a lot of case management. We're the ones that are understanding the situation, making the connections between the various community services, making the connections to home, trying to pull everything in. We are paid to do that. We are doing case management. The Department of Health, through the waivers and other opportunities, provides case management. Senior citizen centers provide case management. So there's numerous conversations or numerous services that can be available. The reason why we separated it out from someone who cares is that there are times where you need to have somebody who's doing case management from a professional standpoint, and then someone to help that adult make the decisions they need to make. Who is that someone who cares? Can someone who cares do case management? Yes. Yes, they can. The context here is if we're involved as an agency and we're working with others, that adult, if they're not able to fully support themselves in their decision-making or their physical care, or even some sort of advocacy, we need to have somebody in place. In a formal relationship, that looks like the guardianship corporation, where there's a formal guardian, and that is that person who cares. So it can get a little bit blurry, but the intent behind a case management was more in those eyes of somebody who's professionally hired to help that person navigate all of the resources, navigate the sources in a short-term capacity for most. It may be long-term if they're on a waiver. And then that someone who cares then can help take over a lot of the day-to-day management. So back to the conversation in May, the spreadsheet, we included that again for reference so that you could pull it out.
Don't do it.
And thinking about the context of that spreadsheet as it relates to the essential services, I think is the conversation at hand. Anything else?
Mr. Chairman.
Go ahead.
So this morning and the other day when I was reviewing this, so then, I know I just keep coming back to this remote or rural. So we have senior centers and they provide box lunches and they go out and they do that. And that's great if you live where there's senior center that does that. And so I think the committee is going to have to look at this a little bit, because if we try to capitalize on the programs that we have, and we see the counties that where and you look at the programs we fund through the Senior Citizen Center, we need to look at those programs and say, similar to what we've done in the behavioral health redesign, and say, for the state dollars, there should be some expectations that these services are provided. And for other dollars, do with as you want. And it would also seem to me, to the members of the task force, that there would be consistency around the state, so that there needs to be flexibility, but there needs to be consistency. And again, I think if we consider how we do that, it would be similar to saying, for the state dollars, these are the expectations. There's some flexibility there, but this is what we're trying to get accomplished. This is the intent of this appropriation to further design, because my years on appropriations, and we've had this conversation on providing services through the community, through senior centers and other aging programs. There seems to be funding with direction that allows for a lot of flexibility, and so there's not consistent. So Director Johansson, I appreciate I throw that out there as a comment, question mark, to see if you're seeing that differently as we look at these essential services, then look at how those are provided on this spreadsheet. Does it not seem that we would start there first? Is that the low-hanging fruit?
Go ahead, Director.
Mr. Chairman, Mr. Co-Chair, thank you. Yes, I agree with that. And I think what I really like about an exercise like this formally is that spreadsheet is a monster. You see a lot of different programs, health, DFS, other agencies, a lot of links to see what's available in each county, and it's a mixed bag, to your point. The kind of harsh reality of what we've been talking about today with various services, transportation being the most recent, is that if you live in Casper or Lander or Riverton, you may have better natural access to transportation than you do if you live in Baggs or Farson. The exercise here, as opposed to taking all of those services that you saw in the spreadsheet and saying, let's go through each one of these and add a column and say essential or not. How this got rolled up, and I really appreciate DFS's approach on this with regards to adult protective service cases for vulnerable adults, keep necking down that population, that this is who we're talking about. Some referral has been made, some state agency involvement has been requested because of an issue going on with this particular individual. What are the outcomes that we see for those clients, and based on what deficit? And that's really these sort of 5 or 6 categories that you see in this table are the common themes that Corin staff or Department of Health staff through our various programs and providers see. This case got this way because we think, or we know, there was a limit on transportation. There was appointments missed, the care wasn't accessed, person doesn't have a primary care doc, there wasn't sufficient or reliable food source. There wasn't a case manager or a friend, family member, neighbor, or in some cases a guardian to make decision making. So these services are really kind of macro level. What, as our 2 agencies discussed it, what are the things that we think this population needs that are quote unquote essential for quality of life, for independence, et cetera, that aren't necessarily, nitnoid detail of programs and services with federal match and certain regulations. And I think from my perspective with that whole Casper versus Farson or Baggs issue is the difficult exercise for a committee like this to determine, is there, based on what we know we have, and you have the spreadsheet and you have all of this discussion, for those areas where we know there are gaps, is there a state role in ensuring as an essential service, transportation services for a vulnerable adult that's identified and referred to the state government in Baggs? That, to me, catalyzes the second step of the policy conversation is, okay, how do we do that? How do we build that? How do we scale it? Who provides it? But I think as you go along some of these domains, there are reasonable debates on, is this a state role or not? Is this a state agency program role or not? And that's what I would really ask the task force to take seriously, because we've, perhaps me, Director Schmidt, maybe yourself, Co-Chairman Larson, are a bit biased because we've seen several large efforts in this state with the reconstruction of the facilities for the Department of Health that the legislature went through that exercise. Is it the role of the state for the state hospital to provide care to this population? Yes or no? And some of those answers were no. And same for the Life Resource Center. We built those facilities according to what was determined is the role of state government. And there were populations that everybody wants to help, but we determined, no, that's the role of either private nonprofit providers. Maybe they're funded through a different program, or the private sector. And I would just encourage that kind of discussion here because that's what lays the bricks for that policy framework going forward if we're going to make a change. And from my perspective, it simplifies it a bit where we're not, and God bless Danielle and members on my team for creating that sheet. This is in no way a slight against that effort because it's a wonderful reference resource. But it's daunting to go through there and say, okay, where do we begin to improve services? This now rolls it up to simplify it. Is there a role of state government to improve transportation resources and have a goal to ensure those for APS vulnerable adults statewide? And if that answer is yes, then policy and financial vehicles can be designed.
So is it fair to also believe that developing a policy to address this would help in the host agency, being DFS, who has statutory oversight of adult protective services, but who depends on those programs and services provided by other agencies, so that there's this coordinated understanding between agencies that this is for, again, we're trying to stifle siloing, right? Does that help in that effort?
Mr. Chairman, from my perspective, it does. And even if nothing were to change, if we take a hypothetical that the APS system, vulnerable adult system, continues to operate the way it is, referrals or shoestring, budget programming continues, we try to access that, we try to set folks up. I think just the continuity for Director Schmidt's field staff to have a good sense, decent sense of what's available and what isn't, that coordination absolutely helps. What can I access on behalf of this person or not? And then if we get into the landscape, potentially making changes to say the state has set a policy that for those APS vulnerable adult cases, we are going to set a policy priority or a policy goal to standardize and provide some baseline level of housing assistance, food assistance, transportation assistance, case management, and friendship or guardianship, however that goes on the scale, then that absolutely changes the discussion. But I think because there's so much interreliance on these programmatic elements, it has to be a joint effort. We can't just say, okay, DFS, you now have a mandate to guarantee these essential services, because DFS will naturally look to what's established, what is potentially scaled in regions or counties or municipalities, and say that's how we're going to do it. And so I think that can be a really instructive, that can be very instructive direction to the agencies to, I'll put it this way, Mr. Chairman, I struggle because I think everybody has good intentions on this task force and in the audience and throughout the state to say, of course, we want to help these people. How do we do that if we want to continue with this piecemeal effort to say, well, we have some things over here and some things over here and some things down here. You might be out of luck if you're down here, but if you're willing to move, there's a few more services there. That could very well be the reality. But if there's an interest in establishing a baseline, then that gives direction to the agencies to, for lack of a better term, take it seriously and let you all as decision makers know, here's what it would take to ensure vulnerable adult programming transportation statewide. We would need to develop different networks, have financial discussions, those types of things. So long-winded way of saying, Co-Chairman Larson, yes, I think it's very helpful and instructive and has to be an interagency effort.
Isn't this fun?
Go ahead, Director.
I do, though, think it would be helpful, and please take this with a grain of salt. During this administration, and you've heard Director Johansson talk about it, I do think there's an amazing working relationship between the agencies. It's not one that I've seen before, but that's because I kind of like him. But I have worked for administrations where there hasn't been the collegiality. So I do think there is a balance between this idea about coordination based on goodwill, but also some coordination because it's expected. And having some of that expectation laid out, I think, for future continuation of this conversation would be helpful. For example, we have it through the Interagency Children's Collaborative. It's a statute. It says that we will work through these issues in regard to high need youth. I'm not proposing that we have some sort of statutory mandate, but it does bring together the needed conversations and a requirement to have those conversations, because we all can get busy with our own internal mandates as an agency And then as we do that, then we have a tendency to maybe not understand as much the needs or the reliance others have on us in order for them to be able to serve and perform their duties. So I don't know where that fits in terms of the conversation around essential benefits. But I do think that we need to be very cognizant that what we're saying today, we were able to do this because we do have a very good working relationship. There will be times where you will have agencies who do not.
Go ahead.
Mr. Chairman, Co-Chairman, I would like to speak in support of Director Schmidt's comments. I don't believe we need a mandated directive, but I certainly think we need an expectation that we work together. And I would like to talk about just a few things. Her mention of safe houses, transportation, and case management. I don't know if we really realize that when you speak of the low hanging fruit and under my department, it may be some spoiled fruit. But however, the expectation that the cost and that we work together, I made myself some notes prior to the meeting. And now all these don't fit the criteria of vulnerable adults, but just incarcerated alone, over 65, we have 395 individuals. We have 619 under parole. Our aging factor. So with those numbers, we're releasing approximately 600 individuals of our citizens back into our communities a year. What impact that would have on Director Schmidt? Historically, we've always looked at ours because of their lifestyles. Usually they're kind of frail at age 55 due to their, multiple addictions and things in the lifestyle that many of these individuals live. And I'll give you some examples that we may not even be thinking about. I belong to an organization. We recently testified in Congress last year, and it'll take effect September 1st. Everyone who's incarcerated doesn't mean you never worked, you're not eligible for Medicare, you haven't worked your 40 quarters, things of that nature. But if you get released, let's say you get released right now from an institution and you're paroled, you're not eligible to receive any benefits until the enrollment period in November. So when you see Joe Namath on television, you're eligible to come around and say. So we had that change because it's really not considered a life-changing event, like you lost a spouse, you lost your health insurance, things of that nature. So folks, those types of individuals, I can tell you, we have our geriatric unit has almost doubled within our institutions. And I realize there's many individuals who will never get out of our institutions, but I'll give you an example. Just in the last 5 years, we actually had 44 individuals that went through our hospice program at our institutions. So my point by saying this, these are our citizens. When we talk about housing and transportation, they're less chance that they're going to get top of the list there. But I really want to think if we want to look at low hanging fruit and really want to look at expenses, I believe those numbers alone will have a huge impact on Director Schmidt and our state's budget. Thank you.
Well said. Okay. Very good.
So,
Go ahead.
Mr. Chairman, Director, I appreciate all of you saying, well, we don't really need this defined, but we need to understand. I don't know the terms you use, but it seems to me that if we looked at in the definitions or in the statutes under the APS section, that then to consider some sort of language that would indicate what these essential services would be. And, this is just starting that conversation, but I think that it needs to be someplace so that 20 years from now, we can look back and say, this is what the intent is, or we understand that, not 2 years from now where we understood the good intentions of the task force. I think it needs to be defined a little bit someplace. Am I seeing that wrong? That's a question to you, Director Schmidt.
Mr. Chairman, Mr. Co-Chairman, so I'm pulling up the definition of vulnerable adult, and that you can find that in 35-20-103. And the extent of the definition is pretty expansive. I mean, it says we must provide for a safety net for all of these things. And so I do think it's an honest conversation to talk about, but what does that really mean? If we're responsible for the expansiveness of all the services, it is a lot of coordination, and it's coordination of only what's available. There's no way that we have to magically create a service, and as we all know, we don't get funded to do that. So the responsibility for all things is larger than what is listed in the essential benefits. So perhaps it's a conversation about that.
Mr. Chairman.
Go ahead.
So isn't that similar? And you were both participated in that when we redefined the role of the Life Resource Center.
Yeah.
We made that a little more specific to understand what the mission of that facility is. And this, under Adult Protective Services and under the definition of vulnerable adults, would then give direction on what we think those essential services should be for a vulnerable adult, regardless of where they live in the state, right? Okay.
Okay.
This is fun, by the way.
It's pretty exciting.
This is pretty exciting.
Good stuff. Further comments? Okay, I noticed that we had somebody signed up online for public comment.
Mr. Chairman.
Oh, go ahead.
So it just, for the public, and, you know, I wish Speaker Summers was here, because he's really the genesis behind this conversation on vulnerable adults, and to look where it was just this orb floating out there in statutes to where we're coming now is really kind of, and we've had to wade through a lot of swamp to get kind of to where we understand where we think we ought to be. And I think it just is some value and to what we're doing. And I'm just really pleased that we're coming this far.
Go ahead, Richard.
Mr. Chairman, this is certainly not something I can require. Once again, I would ask the task force between now and the next meeting, take a look at page 2 of that, on that table that we pulled up on the screen for this discussion, and take half an hour and go through the exercise. I think you'll be surprised when you think through what we discussed last meeting with the volume of services and locations and geographies. That's again, very daunting. But rolling it up into this capital P policy space with these, 6 categories of both essential service and what I kind of dub as the outcomes that lead to, the needs for these types of cases, and think through that role of the state. And we have the quote unquote population defined, but to Chairman Larson and Director Schmidt's point, perhaps that in law could be necked down to the essential population, essential services we're talking about. But go through, we left some boxes blank there to just, have a discussion. Is this the role of the state on a statewide basis to ensure or strive for, housing assistance for these vulnerable adults or transportation services for these vulnerable adults? And then if that answer is yes, and it might not be, but if that answer is yes, then the second step is, okay, then what? And who is responsible for that? And again, just having seen this exercise produce some fruit, Chairman Larson mentioned the Wyoming Life Resource Center. This kind of exercise was the first step at the root of our behavioral health redesign with our providers, with legislators, to determine what problem we're trying to solve. And here's 6 problems that you see here. Problems related to housing that result in APS or vulnerable adult cases, problems related to food that result in APS cases, problems related to medical care, transportation, et cetera. Those are the problems we're trying to solve. And we did this same exercise on some of those larger reform efforts. And I think it sets that baseline of the policy discussion that we're not talking about, improving funding or a service in this pocket of the state because there's a gap. There might very well be, but we're starting at the foundation to say, what should we hope or guarantee as a state that should be available to all of these cases at a baseline level? In different communities, it'll look different, but at a baseline level is the state's role to guarantee these things. So just encourage the task force to go through that exercise and jot down your notes.
Mr. Chair.
So, Mr. Chairman, I had this on our to-do list to staff, and so on our agenda in the next meeting, we'll talk about each of these respectively, and we'll answer the last two boxes. And then also, did we miss a service that they think is essential? And so that'll be part of our agenda in Torrington is while we're.
And I have a request, Mr. Chairman, just be the first item that we discuss. That we do it first, that way it's fresh on everybody's brain. We don't throw any other kind of stuff on top of it, that we have time between now and then. Go through it, go through whatever the staff gives us in the meantime. So we do that first item when we get to Torrington.
Thank you.
Okay. Very good discussion. That's why I like this task force. Okay, and that takes us into adolescents with high behavioral needs. And as discussing with some of these folks about what may be coming forward. I see a hand raised, public comment. Our gentleman online was not available. Is that right, Mr. Wall? Okay, very good. Anybody in the audience? Go ahead. Come on up, Kip.
Yeah, so Kip Dana with High Country Behavioral Health, Chairman and Co-Chairman and Directors. I appreciate this discussion and everybody representing the populations that you're tasked with representing. And at a philosophical level, this is interesting, but then you get down to the boots on the ground in the community. As I've said recently on a DFS staffing case, we're talking about a vulnerable adult who has open wounds and he's failing to take care of his wounds. And he's deteriorating. His house is a mess. He's and this individual has no apparently, we all live in a social context, but apparently has no friends or family or community that's giving him help. So DFS is in there like, what do we do? And you know, one of the advices that came there is, well, let's get an attorney and get his adult rights taken away from him so somebody else can direct him that he has to do this. And then what do we do? How do you force him to go get the medical care? And he's being a little combative with them. So I'm there. Well, does he have a mental health problem? Well, not that we know of, but you got to be crazy to not take care of your house or your wounds. So there's a case. Another case, boots on the ground last September. We got a homeless guy going through Star Valley. He's sleeping in somebody's barn and it gets way too cold to be sleeping out in the barn. And somebody puts him up in a hotel for a couple of days and then they were able to get a hold of me. Schizophrenic, talks to a rock, rubs the rock on his head to get his thoughts going for him. And no friends and family in the area. He's got a mother. He's in his 50s. His mother's living back east someplace. And when I was able to get a hold of him, she helped to then pay back the person that paid for the hotel room for him to be there. But what I did is loaded up his stuff and his bike and everything that I could gather. I went and picked up all the dirty socks in the barn that he was sleeping in and, you know, tucked it away and hauled him down to Utah to drop him off at a homeless shelter. And then got Weber County Human Services involved to help get him some medications and help him get care. But as I look at this, as I look at these needs of these real people, if you just drove 2 hours this direction and went down under the interstate in Salt Lake City, you got a host of vulnerable adults living there under the underpass, and we can't take care of all those people. And you drive down certain sections of Cheyenne, and it's like, now are we proactively going to reach out to these vulnerable adults who need this care? And I like kind of the cautions that Director Johansson is bringing up, like, and I don't want to put words in your mouth so you can clarify, but 60 years ago, 100 years ago, it's friends, it's family, it's community, it's church. The government would not have even thought about getting involved in these people's lives to the degree that we're talking here. So, and it's kind of an odd conversation for Wyoming. How far are we going to create a welfare state? where everybody has all of their needs met, whether it's medical, transportation, food, shelter. Are we really, and I'm not opposed to that either. I care about people, but how far does the government go into making sure everybody has what we would now call essential services? It seems a little to me it just seems a little politically bizarre for such a right-wing conservative state that we are to be talking to that level, like let's create a welfare state so nobody falls through the cracks. And that's my thought. So I like the idea of like, let's really think this through and think like all these people coming out of corrections, vulnerable, definitely needs help. But maybe this population that we're talking about doesn't fall in DFS's lap. It's like, no, we got field officers out there. We got case managers. If they got a mental health problem, we got that system. Let's make sure there are systems in place for those defined populations we know need that extra help. But be careful that we're not now thinking we're on the hook for all essential housing and food and medical care and transportation for everybody who now shows up as a vulnerable adult.
Go ahead, Mr. Chairman.
So Kip, I really appreciate that caution and that observation, particularly from the world that you live in. But I think that's exactly what we're trying to do. So who is a vulnerable adult? We have that in definition, and what's the role of the state in doing this? And is there a role? I think to this point we would say yes, but to what extent is the role of the state? And so this being not the first, but maybe the second or third step, as we've defined and says, well, there probably ought to be some essential services that sustain life and keep people protected and preserve their rights. Right. And so this exercise went through to go from a list of maybe 15 or 20
down to
that we
6
could do
or so.
we could do down to 6 or so that need further refinement. So now with that said, do you think we're off track in the process, or?
I'm a little bit as I sit back here thinking about I wasn't around 60 years ago, but what's happening in our communities? These people existed then as well. Did they all just die? Nobody cared about them. And is this pendulum swinging here with government? And now government is now taking over what friends and family and community and churches used to do, because those infrastructures have fallen away as people are living more and more isolated lives, not connected to friends and family, community and church. So now they're this truly isolated, vulnerable adult. If that's the direction our society is going, is this the solution to that? I don't know if this is the solution, but if that's the cause of the problem, we have these isolated individual, adults living. We have people living in very low, shabby places right here in Kemmer they certainly get their pack of cigarettes and take care of that all day long out on their porch, but their health is deteriorating. They've got diabetes. They're not getting the care. I'm just like, where do we come into this?
Okay.
So then I would follow up, and I would say that I'm struggling a little bit to understand where the church, where the locals would come in and provide for guardianship.
Right.
I'm struggling using the example you used, a guy not mentally ill, choosing to live in might be fine to him, but maybe to the rest of us isn't appropriate.
Right.
You live in a community where church is prominent. They haven't stepped in and done anything.
Right.
So who should? And in doing so, who should protect his rights? Is it going to be the church protecting his rights? Who is it that's going to do that? And so the question is do we get him committed somehow, or do we get him the help he needs? And so is that a role of the state for these limited populations that we find being vulnerable? And I think those are the questions we're trying to ask, because
Yeah.
it appears to me that there are some gaps where the state has a role to protect rights, to ensure that these things are taking place in an appropriate way. Do we need to expand this? You're right. I believe you're right that we need to be careful not to expand government to universal health care or whatever we might turn that be. But there's a role of the state, and we're trying to refine that. And that's so, again, does that make sense for, I mean, the reason I'm asking these, because we've had some very frank conversations, and I respect your opinion and understand the world that you serve, but it seems like this would be a reasonable thing to try and get resolved and set so that it could prevent expansion as well as provide service to a population.
Go back to the DFS caseworker sitting in Afton. They are going to do something with this person, and they're going to grab every little resource they can, which could include, trying to get the rights taken away as an adult and somebody else taking responsibility for them. Yeah, it's like in statute, we're rolling on something, but I would just want to, my thoughts are just stepping back and question the philosophy of the whole thing. The worldview that we're moving into is how much, when I looked at that list, I'd be like, oh my gosh, if somebody starts to perceive that that's their essential rights, where have we gone? That now government is responsible to make sure that those people get those things, even though the list went from 16 to 6 or whatever. It's like, is that the welfare state we're trying to create?
Mr. Chairman? Go ahead. Good.
And I'm just philosophizing with you. I have no answers. I'm just hearing the comments here and thinking, oh my heavens.
Go ahead, Rick.
Thank you, Mr. Chairman, and thank you, Mr. Dana. And I think you bring up an interesting question and philosophical debate. I would like to suggest, though, that government has already decided that it is our problem to solve. And the statute says the department, meaning the Department of Family Services, shall coordinate a protective services program consistent with this act with the goal of ensuring that every vulnerable adult in need of protective services will have access to protective services.
Yeah.
And so where you're hearing essential services, the statute calls it protective services. And that was the comment that was made by the speaker at the very beginning of all of this, is that the department has a responsibility. However, define a protective service. And so if the department, which is the state, has that responsibility, then having some definition of what that means will help us fulfill that obligation, while also being aware that there is a line before we step into a larger state issue of all things to all people, which I think is what you're cautioning against.
Yes, and caution against the people living under the interstate in Salt Lake City. Now they want to cross the border, come into Evanston and say, hey, I'm ready for my essential services. It's like, well, okay, let's get them on a bus and take them to Cheyenne. Stefan will take care of them.
Well, Mr. Chairman, my basement is not roomy, but it's
Yeah.
comfortable. I just want to add, because this, to Chairman Larson's point, this is what I think the two agencies are encouraging, is without answers in mind to say what's the role of the state with this population. We're not talking everybody. It's not, these types of, these 6 categories for the entire citizenry, but when these to answer the question that you raised, Kip, which is a good one, there's already an expectation now. Corin read the statute, but we get under pressure both in family services and in the health department, often in the legal system, from judges, from courts, saying, we have an expectation that you're resolving this issue. And we sometimes have to put our hands up and say, but there isn't anything available in this town or in this region that's going to solve this person's problem. And to your point, this individual has not been civilly committed. Rights are not taken away. But yet there is still an expectation that the government agencies are doing something about it. And I think the point of this exercise is exactly in line with what you're talking about of maybe there are some no's on here, some no answers that we all know, and you hear it in the behavioral health world. We hear it in the Department of Health, even broader world. Director Schmidt and her staff hear it all the time and see it all the time, that housing is an issue. It's an issue for recruiting staff. We don't have housing stock. It's too expensive, not enough units available, et cetera, et cetera. So maybe there's a no there from the wisdom of the body that says, well, all of those things considered, is it the role of the state to guarantee some baseline of safe housing? Maybe not in totality, but maybe maybe it's emergency services where on a temporary basis, like you mentioned, we have to get this person, just from a human perspective, out of this situation now. Maybe it's a week where we could help spur some action locally to clean up a house or fix a broken roof or utilities or what have you. So your comments are very well taken, because I think that's, at least from my perspective as an agency director, the kind of engagement we're looking for is what is that baseline role of the state? And through many of these categories, I would expect that there would be differing opinions, but also expect that there's probably some, no, this is not the role of state government. This is the role of local communities, local action groups, nonprofits, et cetera. What the state should be involved in with vulnerable adults who get referred or are part of these cases is X, Y, and Z, not A, B, and C. And that's really, I think, the exercise here.
That was all my comments.
Okay,
Appreciate,
Director Shannon.
yes.
Mr. Chairman, Co-Chairman, I'd like to make a comment to Mr. Dana. I appreciate your input. And you spoke of philosophically why we would do these types of behaviors. My experience has been when all public safety nets have failed, and instead of going to Stefan's basement, they come to mine. I have.
Yeah, yeah.
And very clearly, I as well strongly do not believe in a welfare state. But I also have a responsibility after almost 40 years of corrections to realize it's not our job just to keep people confined. It's our jobs to create less victims.
Yes.
And by addressing these needs with this type of population that Director Schmidt deals with, we're reducing victims. And what's the cost of that?
Yes.
So that's why I made my comments.
And I don't often hear your voice, and I appreciate your stepping up today and saying, hey, this is a big population that I'm very concerned about. They'll recidivate if they don't get the care when they come out of your facility.
Not only that, I think a small portion of that will cause more destruction. And I'm trying to point out, if we're really trying to spend our money wisely and create less victims, I think that kind of sticks out like a sore thumb. So.
Yep. And we're here to support that. So thank you for your time.
Go ahead, Mr.
So Kip, I just one other comment, because I think you bring up a really good point that, if we put this in place, there's that population down in Utah, and we don't really favor the idea of that population coming here to take care of our resources, probably no more than they appreciate
Me dropping a homeless guy off.
dropping somebody from Star Valley
Yeah.
down to a homeless shelter in Weber County,
Yeah.
right?
Yeah.
That's funded by the state of Utah.
Right. Well, that's called Greyhound bus therapy.
Yeah.
It works everywhere.
Yeah.
I see someone else standing. She's running to a mic. Go ahead and introduce yourself.
Yes, thank you. I'm Emily Smith with Wyoming Guardianship Corporation and chairman and co-chairman. I just wanted to take a couple of seconds to talk about the really, really complicated, complex nature of the folks that APS is opening cases on. And so Director Schmidt talked a little bit about the opening cases versus just all the calls you get, because they get tons of calls that are just like, this person's doing weird stuff and can you go fix that? And of course they cannot. But when they open up cases, those are some of the cases that we call at my office, the Dateline NBC cases, because truth is way stranger than fiction and you could not make some of this stuff up. They are wild. And they are really, really hard. So I think we all know that. But I wanted to give you a little bit of information about some of the cases that we have taken in the past 18 months from the Department of Family Services and referrals as guardianship cases. Now, Wyoming Guardianship does a lot of other things besides guardianship, but just for guardianship, 11 cases that we took were in the hospital long-term, more than 3 months. one case, one person had been in the hospital in Campbell County Memorial Hospital for 18 months. He was living at the hospital because there was no safe place to discharge this person. We have another person who's in the hospital in Sweetwater County who I've had to leave and go talk on a couple of phone calls about. She's been there since November. So these are really, really difficult cases. And the reason why these folks are still in the hospital is because they can't be discharged safely. These aren't folks who are choosing to live in a way that we just don't understand. They actually cannot, they don't know what's going on. They don't know where they are. They're not oriented to person, to place, those kind of things. 8 of the cases that we took were financial exploitation cases. 17 were neglect. And I want to talk just very briefly about those neglect cases. I'm calling neglect maybe not something that the Department of Family Services would call neglect, but in those cases, those people had appointed a power of attorney for themselves. And that person had chosen not to follow up on that duty. So they'd actually exploited or abused the person. So they'd appointed their neighbor, their sister, their daughter as their power of attorney. So, when we talk about our friends, our church members, our family, coming in and making decisions for folks, 17 of the cases that we've taken in just from the Department of Family Services in the past 18 months, their power of attorney chose not to follow up on their duty, or they actually harmed the person that we're talking about. So, I just wanted to just give you guys a little bit of insight into some of those cases, what we're dealing with. And of course, I think Director Schmidt and all of her staff is amazing because, like I said, these cases are wild and you could not imagine in a million years some of this stuff that's happening. If you guys have questions, I'd be happy to answer, but I just wanted to mention those things.
We do, Mr. Chairman.
Just was curious, the ones that extensive stay in the hospitals, Campbell County, Sweetwater, are they titled or they, what the extensive stay there is because?
Co-chairman, chairman, that's a great question. Those particular cases, although we have taken some that were titled, these were not. They just were unable to discharge them because they weren't oriented enough to go home. They could not care for themselves in any way. And there was no one to take them. So nursing homes wouldn't admit them because they couldn't legally sign themselves into the nursing home, sign those documents because they didn't know who they were, where they were. And they weren't able to go home because they couldn't manage figuring out how to get all of those services in place to keep them safely at home. So I think they were waiting to try to figure out what services could help get them discharged.
Doesn't that seem like a fit for the WLRC?
Ooh, good one.
Director, go ahead, sir.
Mr. Chairman, at the risk of making admission decisions during a legislative meeting, potentially,
Yeah.
and with Emily's comments, which are also well taken, these are cases we're seeing more and more of at the retirement center in Basin, which is a state nursing home that we oversee. And we're becoming known as a facility that will admit populations that other nursing facilities will not for whatever reason, or that involuntarily discharge them for whatever reason, whether those are, psychological behaviors, aggression, advanced dementia, those types of things that, again, going back to this point, we keep coming back to, there's whether we've designed it or not, there's some sort of safety net somewhere. That can be a local hospital, or that can be a state facility, or an expectation of field staff with an agency to try to coordinate something. So the safety net's happening. But yes, I think in some of these cases, those options are pursued and explored, and sometimes they're appropriate and doable, and sometimes they're not.
Well, and I think what stimulates that thought, and I wasn't suggesting that it is, but it was a question because I think sometimes we don't know that resource is there, or the retirement center. And so a hospital, Campbell County or Sweetwater County, may hold that person, and who's paying the bill? They can't discharge them.
Right.
And so is it their role to cover that indigent cost, or are they getting reimbursed? And I just, fair conversation, I think.
Thank you.
Takes us back to a conversation about uncompensated care.
Yeah.
Very good.
Absolutely. Thank you so much.
Thank you very much. Further public comments? Have we gained anybody online? We've not gained them. We're not very popular online today.
After all this?
Yeah, I can't believe it. So let's do this. It's right now almost 20 after 3. Let's take a,
Thank you.
let's do a 10-minute break because everybody needs to stretch their legs and have a drink of water, coffee, whatever it is. And we'll be back at 3:30 to run to the finish line. Are we ready? Okay,
Liability insurance, that's where we're.
yep. So we're up, yeah, the adolescents with high behavioral needs. And I've been assured that this is kind of a short length topic by all who are going to testify. Let's start that off if we would. Donna, would you like to lead us off?
Sure. Mr. Chairman and members of the task force, LSO prepared a fact sheet that you have in your meeting materials in response to the last May task force meeting. LSO was asked to reach out to other states and see if the provider liability insurance issues were happening in other states, and if so, how states had responded. I'm not going to present the fact sheet since we're running behind, but I'd be happy to answer any questions.
Hey, committee, if you've had a chance to look through there, hopefully you have. Any questions or comments about that? It's pretty self-explanatory. Thank you for the hard work. You did good. Any comments or questions?
Second time
committee?
she's provided.
She's awesome. There's just no way around it. Okay, no questions or comments on that. It's pretty straightforward. I think it got us where we were talking about. Okay, the next item says provider facility liability insurance challenges. And I know Andy has some appropriation. I don't believe that Andy Schwartz came online.
He
He
was
did.
not going to be here today.
Yeah, so that's fine. You pretend that you're him for his part. And go ahead, Andy, go ahead and introduce yourself.
Thank you, Mr. Chairman. I will try to impersonate the other Andy. Andy Somerville with the Wyoming Association of Mental Health and Substance Abuse Centers. And Mr. Chairman and committee members, my presentation is very short, and to say that we are still working on information from the last meeting. This committee had requested, we had an option from a broker to go through some claims, and they are still pulling that data for us. So as I'm hopeful that I will have that early next week, and we will forward that to the committee as soon as we get it. But Mr. Chairman, I have no other new information on the topic.
Can you give us a little bit of a general feel as what you might be expecting to hear or?
Yeah, Mr. Chairman, what I'm expecting to hear is that the number of claims relating to property damage is probably it will be. It's the largest number of claims. Those property damage claims are rarely less than $25,000 approximately is what we were looking at. Most of the rest of them, the centers just pay for themselves rather than turn in an insurance claim. The professional liability claims are much fewer and far between.
Very good. We'll look forward to you hearing. That was a lousy interpretation of Mr. Schwartz. Right?
I know it was.
You know, he sings. Does a committee member knows that Mr. Schwartz is a singer?
I do.
And he also plays the saxophone.
Very good.
No,
Can you do that?
Mr. Chairman, I can play the saxophone, but not
Okay.
as well as the clarinet. So I'd still make a poor impression of Mr.
Okay,
Schwartz.
well, maybe we can have a band at our Torrington meeting. Very good. And we have some other folks that jumped up to the table. Go ahead and introduce yourself. Oh, you got to turn the light on for us.
Okay, thanks. Hi, I'm Sarah Cavallero from Teton Youth and Family Services and also from Wyoming Youth Services Association. I am traveling today with my daughter Callie to a lacrosse tournament down in Salt Lake. So I told Andy he didn't need to come and I could serve in his place.
How about we have Tally introduce herself to us and tell us where she's at in school and how old she is.
Hi, I'm Callie Cavallero and I'm 12 years old and I am about to go into 8th grade and I just finished 7th grade and I'm really happy, but yeah.
We're happy for you and welcome to our committee. We always appreciate it when we have any young people come to our committees because mostly we have old people.
So, Mr. Chairman, if I
Go
may,
ahead, Mr.
Callie, so how many lacrosse teams in Wyoming? Is there
I have
besides
no idea.
two?
Two?
Two.
Wow.
Good for you.
How many teams will be at the tournament you're going to?
12.
12 teams. The rest are all from Utah or?
All over the West.
Wow.
don't you tell him your position?
I play goalie.
Goalie.
Yeah.
Whew, you are tough. You know, I went to University of Wisconsin. Yeah, I went to University of Wisconsin and that's the last place I ever saw a lacrosse team. So that's cool. Very good.
We're glad
Welcome.
you're here. Thank you.
Yeah, very good. Okay, back to your mom.
I just have a couple things to cover. I really, really appreciate your conversation that you had earlier. It is exciting to hear the conversation about what does the state provide and have that on the floor. I think I've thought about this for years and it's really exciting to hear the conversations happening. And to Corin's point of having good relationships across departments, I've been doing this for a lot of years and this is the first time that I really have been in meetings with Department of Ed, Department of Health, and Department of Family Services talking together, and it's been really hopeful conversation. I also want to thank you all for your support this year during the legislature for the rate increases through DFS. That is a game changer for us and really gives me some hope in how this partnership continues to work forward. Liability is an interest. I was thinking about this as on the drive down, and liability really probably is a core piece of what we assume as partners in the state. And so I think having this discussion moving forward is really interesting to me of like, where do we land on whose liability, whose kids are these, who's holding the bag essentially at the end of the day for kids that are really hard to keep safe. And that's really, what we look at is, I look at constantly, how are we keeping kids safe? Because when we can't keep kids safe, that is a liability on us. And we need to be able to say, we can't keep kids safe. They need a different place to be kept safe. So I think this conversation is great and exciting. And I think we have some solutions that I think we can work through. I think we met with Department of Family Services earlier this week, and my biggest takeaway from that is that we need Department of Insurance's help to navigate this. I don't pretend to understand or know what insurance liability deals with when they look at our applications. The one piece that I will say that we talked about as a collective of being really mindful of not changing our protection systems for kids and families for getting liability insurance. And I just want to make sure I just say that it's an obvious, but I say that because I think it is easy to look at we looked at this week, our insurance applications and some of the specific questions we have to answer as providers, like, have we had an investigation this year? We get investigations every year because we have incidents with kids that are having a hard time, and we want investigations because we want DFS to be the check and balance to make sure that I'm doing my job. So I think we just have to be careful when we're having these conversations and working through the nuances of what liability is to make sure that we're not making our system less safe for kids and families. And I think that's my biggest piece that kind of came out from the last meeting, between the last meeting and this meeting. That was the thing that I was like, okay, we need to make sure that while we're doing this, we need to keep this at the front.
Question, Mr. Co-Chair.
Thank you. So my recollection of the conversation is I don't think anybody from your organization ever suggested that we dilute the requirements. If there's a need for investigation, there's a need for investigation, but that perhaps language for less severe, using the term investigation when it may not be necessary, might improve that insurance need. And I might look at Director Schmidt, but I think, so is that part of the conversation? And is there ability to make some of those adjustments without sacrificing the intent behind?
Don't know, which is why I think we need the Department of Insurance's help. For me to answer a question no on an application, I want to make sure that we know exactly 5 years from now, if we get sued, I want to make sure that the insurance agency can't go back to my application and say that I lied on it based on what their assumptions are in their questions. So I think pulling the insurance groups in is what we need help with.
Go ahead, Director Schmidt.
Thank you, Mr. Chairman. In a little bit more elaboration, I think to your question, Mr. Co-Chairman, and for the benefit of everyone, DFS wears two investigative hats. And so in one part of our agency, we adhere to rules and regulations around a physical plant of a location. So those are our licensing rules, as we call them, and we have them for childcare centers. We have them for all sorts of substitute care providers. We believe we have a little bit more flexibility in that world because so much of that is done through rule and reg rather than through statute. We also do investigations when there's an allegation of abuse and neglect of a child by a caregiver. So we may be in a facility for 2 different investigations around one incident if there's an allegation of abuse or neglect. I don't believe we have any flexibility because of the statutory language around an investigation of abuse and neglect. I do think we have some potential conversation around, are there different stages or phases of looking into an incident? Because there are times where most of the time, what we find, if there is any type of rule violation, it's fairly minor. And I think that is where we don't want facilities to get crosswise with insurance over a rule violation that really has nothing to do with something that insurance would care about. So we're working with our AGs to kind of look into that a little bit further.
Okay, thank you for the comments. Very good. Appreciate you coming, and we'll probably hear from you again.
Yes, I appreciate your taking this topic up. It's very dear to my heart because I watch it happen on a daily basis. So thank you.
Very good. Have the insurance commission. Yeah. Okay, let's go ahead and bring them in. I really hate this behind my head. Oh, I see a smiling face. Go ahead. If you can hear me, go ahead and talk to us.
Okay, thank you, Mr. Chairman. My name is Tana Howard. I'm the Deputy Insurance Commissioner for the state here. And my comments are brief too. I've kind of gathered with the different associations and also spoken with DFS regarding this. And we're still researching and getting some additional information. We got a list of insurance carriers recently, so we're going to dive into a little bit deeper. But I do have some information for you. I didn't want to leave you completely hanging. So, some of the things that we talked about with the associations and in the last meeting was also, the cost drivers of insurance and then the availability of liability insurance. So, this is something, cost drivers of insurance. This is something we also briefed the Joint Corporations Committee about a couple months ago. In Lander, it's a hot topic in every single state, not just Wyoming, and every single market. It's a hard market. It's very expensive right now. Some of the things that we're seeing, obviously, I mean, everybody's heard it within different markets, their own, bills that they're seeing at their homes, but obviously, inflation is causing a lot of these, right? The insurers are seeing a 30% increase in both building materials and, labor costs, but that also goes to different types of labor costs, whether it's, litigation and things like that. Those are driving costs for insurance. Obviously, the same insurers who are writing this liability insurance, the reason I kind of pull this in is because the same insurers who are writing this liability insurance are the same insurers who are writing the home, the auto, or the commercial property insurance. So they have the same license, or what we would call a certificate of authority in our state. So these cost drivers of severe weather, whether it be, and natural disasters, the tornadoes and the wildfires, and all of that is affecting the rates of insurance. So it's causing this hard market. Last year, 2023, insurers saw 28 separate billion-dollar events. So obviously that's going to have a large effect on rates, and that's why we're seeing it. But just to kind of speak about the Wyoming specific market, we have a little over 1,200 insurers, and that has remained steady for the last 5 years. We average about 10 to 20 new insurers each year. That has also remained steady. We're not seeing massive exodus or pullouts, of the market. So that's good. We're not seeing, and this is something with the rate increases that we're seeing in every single state. It's being nationally monitored through the National Association of Insurance Commissioners, but also our federal counterparts as well. So Wyoming in general is a competitive market. We know there's constraints right now and challenges, but we would consider it healthy. The second issue, talking about the availability of liability insurance, is something that that we're still needing some more information on. But what I have from you today is, in terms of medical professional liability, currently Wyoming has 10 insurers that make up about 80% of its medical professional liability market. We have 22 total insurers that are writing this type of coverage in Wyoming. And how that compares with other states is pretty competitive. It's always been a harder market with that medical professional liability. But we're right on point with our surrounding states. Utah has 13 insurers within that 80% of their market. South Dakota also has 10, and North Dakota has 11. So for those more kind of rural states, we're not an outliner. We're right in line with other markets. Now, I will say that medical professional liability, the market shares that I have currently in those numbers don't specifically talk about the providers who are or the insurers who are providing youth services or mental health specific, provider coverage. This is medical professional liability as a whole. So it's every type of medical professional liability. And we can work to dig down a little bit more, regarding to this specific area. That's just not something that we have data readily available on. And so that's why we're reaching out to the insurers and the different stakeholders to try to get that information. In terms of general liability and maybe that, premises liability that we're talking about for the facilities, we have a lot of insurers. We have about 50 insurers who make up 70% of the commercial liability market. We have 450 approximately that wrote premium in 2023. So there's a lot of insurers in that market. Now, again, commercial liability is a very general term, so that's not specifically saying liability insurance for these facilities or organizations, which we understand and we need to do some more digging on. We have done some policy searches. Policies are required to be filed within the Department of Insurance. So what we found is we have about 10 to 12 insurers who have specific residential treatment or behavioral health type facility policies, liability policies filed with the department, which based on some of the information that I just received today seems on point. We got a list of insurers from the association. So that seems to be in line. We've also heard testimony in the last meeting about some of this risk being placed in the surplus lines market. We also did a search in the non-admitted, so insurers who are not licensed within the state, but they can still place that business for harder risks. And so we did do a search in our surplus lines filings, and we had about 10 policies that were filed over the last 18 months. So not a significant amount. It would be in line with every other type of market. The market is available. Not admitted is there, but there's not a significant amount of business that's going there. We also reached out to a few brokers. The brokers are the boots on the ground per se. They're the ones who really talk to the insureds and the underwriters who work for the insurance companies to really diagnose the risk and what the issues are. So we've done a slight kind of poll with some producers and brokers that we contact regularly. And what they've really talked about is, that the market is hard. It's always been a hard market, but it's even harder now. And the cost is high. So the real general consensus that we receive from brokers is the coverage is available, but it's definitely pricey. So, and it's just more narrow than it was a few years ago, which is pretty much in line with every other type of insurance that we're seeing right now. So really, just to wrap it up, and I know you guys are running behind, but I think it's important to say, that the department's absolutely willing to research the issue more and look into and facilitate the conversation between insurers to see, if there's a bottleneck or, like was previously discussed, the applications and things like that, if that is a hang up, and some of the conversations I've had recently with DFS, those are things that we want to have a conversation with the insurers and kind of drill down of what maybe the issue is with these insurers. It's not a market that every insurer really wants to get in. It's not the most profitable. But, I do want to say, as regulators, right, we have a certain balance, especially with insurance. We want everything to be covered, but the department can't make an insurance company cover a risk, right? And I'm the bearer of bad news, unfortunately, on that. But we can facilitate that conversation to see, why the appetite for that market isn't there. It could just be because of the market conditions, or it could be something else. And that's something that right now we're trying to drill down to and get more information for this committee. So with that, you know, I stand for any questions, and I'm happy to take any direction from the committee if you tell us what to do. Other than, you know, what we're already doing, we're happy. We're still researching for that for you guys.
Questions, comments, committee? Mr. Chairman, I missed most of that, so go ahead.
So Ms. Howard, if I wouldn't mind, and I don't know that you have to, I'm going to turn around and look at you and say, I don't know if you don't need to give this to me here, but if you could either send it to us or whatever, but I'm trying to, as you provided that information, and my takeaway is we have providers and insurance is there, pressure on the insurance is high and it's costing more. I'm trying to understand though is when we look at insurance in our adolescent mental health providers and our community mental health providers are looking to get insurance, do they do that under one policy? Or are they insuring the professionals within their organization in one policy? And if so, is that the higher, and is that because of malpractice, or is it the organization liability as an organization? And so they weren't implementing the right policies and somebody died and you know, so there's a responsibility there. Or is it in the physical assets? So the physical assets need to be maintained, ligature, all of these requirements we see for these populations. If it didn't meet that, there's a risk. And so is the pressure on all three of them? Is there one that's abnormally high over the others? I'm just trying to refine that a little bit more to understand where those costs are. You know, and Mr. Chairman, I only go back from my construction days, and we might have of course, inland marine, and then you had your professional liability, and then you had you had 2 or 3 policies. And as I listened to these folks, in my mind, I was just thinking that I've got my liability insurance, but I think that was naive on my part. So if you could maybe share a little more information on how you see that, and then get it to LSO and they can distribute it. Am I making sense? I guess that's even a bigger question.
That's the biggest question. Did Representative Larson make sense? Ms. Howard?
Mr. Chairman, Representative Larson, Chairman Larson, yes, you made sense, absolutely. And, you know, a lot of these conversations with the stakeholders and talking to Ms. Somerville yesterday was that the real struggle is the professional liability piece. You know, all these facilities, just like you're talking about your construction days, they have multiple policies, right? They're insuring not only the physical property, but also the liability of the physical location itself, but also the professional liability of its employees and the services they're providing. But as well as, I mean, there's a multitude of different policies. And that's really what we're trying to diagnose and get, you know, some more information on of what policy is really the struggle. Based on my conversations, it really seems like it's the professional liability piece and that premises liability, but related to the services that are being provided at the facilities. And that's what we're trying to get more information about. Yes, but they do have multiple policies, and every facility really does. I mean, cyber policies, different things like that. So, but we can definitely get some more information, and that's what we're trying to drill down and get it to the committee and LSO. Absolutely.
Very good. Thank you. Thank you, Ms. Howard. We'll be looking forward to further conversation. Further questions, committee? And before LSO reminds me, public comment. I don't know. Go ahead. Come on up, Kip.
So Kip Dana with High Country Behavioral Health. I know that this is under the heading of adolescent. but I do have a question on insurance if she's still available. And that is for correction facilities, jails. If I put on my insurance application that we're going into a correctional facility at all on a regular basis, it about prices us out of anything that we could collect by billing for services while we're in there. So I was wondering, I know that this is an adolescent topic, but I'm wondering if she has any insights on why the professional liability in a correctional facility, a jail, because we're not going into the prisons, is so high, and if there's a way that the insurance commission can be part of fighting for that to be lower.
Good. Ms. Howard, do you happen to still be around?
Yes, Mr. Chairman, yes. You know, I mean, this isn't a,
Did you hear that?
yes, sir. Yes, Mr. Chairman, I did. I heard that. This isn't a market that I mean, related to that specific situation that I've researched, but just the general consensus of insurance is, you know, insurance companies see any type of change as an increase in risk. And when there's an increase in risk, there's an increase in premium. And it applies to every sense of the word, right? When you're driving more, your insurance premiums go up. When you are, you know, going into a facility such as a jail, insurance companies, based off of their modeling and calculations and underwriting, believe that's more risk and therefore, right, the rates increase. There's nothing within the insurance code that we regulate to where we say you can't rate based on those things. The things they can't rate on are based off of discrimination or certain things such as that. Our market, like I talked about, is competitive, so we do not regulate rates within the state of Wyoming. Insurance companies do not have to file their rates. They don't have to notify us. Only if those markets are non-competitive do they have to file those rates, with the exception of long-term care and Medicare supplement and title insurance. Those are the only rates that have to be filed with the department per our code. But, you know, I mean, insurance is such a tricky game because with more regulation generally comes increased costs as well, because insurance companies need to comply. But at the same time, they also have to be regulated to make sure that, you know, the business is fair and available to everyone. So I'm glad I'm not in the legislative body. I leave those decisions to the committee and the legislature.
Okay, yeah,
Mr.
just a
Chairman?
curious thought, because I know I'd hate to have the local Lincoln County Jail be classified with prisons in Florida where there's riots, and now insurance rates go up in Lincoln County because of that. I think of the jail as a fairly safe location because there's guards and things are locked down pretty well, and often the counseling is behind even glass. And so the idea that we could be priced out of an ability to actually go in and provide services at a decent rate for our time is a bit of a prohibition that we might, as providers out here in the field, might have to reconsider. And yet we want to honor the local sheriffs and see this as a high risk state level and non-state level judicial, justice involved clientele. So
that's an interesting concept, because I used to go into the jail as well. That's why I did their intake physicals, and it didn't affect my insurance at all. That's interesting.
Maybe it's behavioral health riskier, huh?
Because they trust me. I don't. Anyway, Director Shannon, you had something. Go ahead, sir.
Mr. Chairman, Co-Chairman, Mr. Dana, would that rate, one consideration, that rate would be set by the amount of liability insurance set forth in the contract by the county solicitor, correct? Could
Go ahead, Mr. Dana.
I'm not sure the county solicitor.
well,
is, but-
when your contract with the county would specify a specific amount of liability insurance required in the contract, correct?
No, it's actually so we apply for general liability, professional liability, and then auto insurance for each of our locations. So
Right.
it's just our professional liability application for all of our therapists in the 7 counties where we're here throughout the state. So the county jail is not requiring us to prove a
You have
level of
insurance.
liability.
Okay, thank you. Mr.
Yeah.
Chairman.
Director Shannon,
And
go
Mr.
ahead.
Chairman, really quick, for Kip, and this is not a question you have to answer now, but you know, we were talking about adolescents, and I think it dovetails with this adult population, especially with behavioral health redesign coming and the expectation of that as a priority population. Jail-based services will be a part of that. So the question for you all to ponder that I would like to have discussions about is, do these, and to what extent do these insurance barriers keep you as a business from making decisions to go into that location? And I know it likely varies by provider, but if there are things that we need to work through, again, whether it's adolescent side or adult side on, you know, different types of agreements between the state, in this case, a county correction facility, and the service agency, which would be you, then we should explore that, because what we don't want is for some sort of cost prohibition on liability coverage, to prohibit the type of service that we will be expecting of you. And so again, you might not have the information right off the top of your head, but what I'm curious about is, to what extent is that a barrier? And I'm not questioning that it is,
Right.
but is it a primary barrier of why jail-based services are difficult to implement? Because that will be an expectation, you know, under the redesign. And as we've discussed as a group, we want this to evolve over time. There's going to be issues to tweak and work out. And if this is one of them, I just want to get on that early.
Yes.
Ms. Somerville.
Mr. Chairman, Director Johansson, we haven't had a lot of discussion between all the providers, specific related to jail-based policies, but we will do that and we'll round back with you.
Yes. Thank you.
Torrington, we'll hear from you again. Very good. Okay, committee. Any public comment on that? I almost did it again.
Scared them all off.
Nobody, now that I'm asking, right?
Attrition. Yeah.
This is my favorite part of committee meetings, is the crowd gets less and less. By the time we get to the last item, there's nobody here. Okay. LSO is gonna need to talk to us. They're getting bored over there. We got a couple bill drafts we'd like to hear about.
Mr. Chairman,
Yes, go ahead, Mr. Chairman.
could we ask Anna to do the treatment court amendments first? And I think, Mr. Chairman, if I recollect, that's 29, version 6, I believe. And I believe committee, that one we approved the amendments, but we waited for LSO to get the amendments incorporated before we voted on it. So
That's correct. We'll do that one first, yeah. And you can go ahead and you can do it from there.
Thank you. Thank you, Mr. Chairman. So there were a few amendments to this draft. First off, the bill draft now amends the definition of applicant on page 2 to include one or more governing bodies. The definition of program is also amended to include one or more programs. And these changes were made to allow supervised treatment court programs to create regional or statewide programs. The only other point I had was that on page 3, we have something here involving entering a guilty plea pursuant to Wyoming statute 713-301. I was wondering if maybe the task force would like to include the other deferrals that appear in statute. There's 2 others. One's for domestic violence and one's for possessions, drug possession. And then on page 4, there was a slight change. It now says a court supervised treatment program may accept participants from any other jurisdiction in the state, and just leaves it at that. It kind of simplifies it compared to how the older version of the bill draft did. And those are the changes, Mr. Chairman.
Okay. Committee see no change. Go ahead, Mr. Chairman.
Mr. Chairman, I think we ought to vote on the bill as we amended it to date. And then as we move that to judiciary, that would give the court's time to digest and maybe consider we add that in, those other 2 amendments. Anna, is that okay with you?
Yeah, and understanding that we'll actually assign this or request another one of the standing committees to take this, and at that time they could do that if they needed to. Is that agreeable and understandable?
And Anna, if you wouldn't mind, would you just reach out to Elisa and with what you found and get her recommendations? I just kind of want to get this in the works for judiciaries before they run out of time.
I can do that, Mr. Chairman.
Very good. Okay, with that in mind, committee, would somebody like to move this bill?
I'd move the bill.
Second.
Second, I heard a second, but I don't know who said it. Director Johansson said it.
So, Mr. Chairman, we don't have anything new or do that. The amendments are as we had adopted in the last meeting, so I'd call question on the bill.
Mr. Chairman,
Go ahead.
I would just note that Mr. Birmingham is online, in case he wanted to weigh in on any of this.
Don't be sneaking up behind us like that, sir.
Well, let's,
Go ahead. Let's take your comments here. while
yeah,
you're there
Mr.
behind.
Chairman, and I apologize for sneaking up behind you. I just want to reiterate the support that State Court Administrator Elisa Butler expressed in our last meeting to these amendments. The branch certainly supports these. And I also wanted to, perhaps after this vote or when you deem it appropriate, Mr. Chair, raise one other item on behalf of the branch that relates to this Treatment Court Act. Further changes we may want to consider in future meetings. Well, I just would like to raise that when you think it would be best.
So, Mr. Chairman.
Go ahead.
So, Ben, as we started this, didn't know that you were on, and Anna brought up, if you've got that bill handy, if you would look at page 3, and I think it's down on lines 12 and 13, is that not correct, Anna, where we reference a guilty plea to 713-301, and she wanted to know if we wanted to include other reference. Anna, would you explain that? But would like, if that's something you'd want us to do today, we were going to hold off because we hadn't heard from you and we could do that in judiciary. But if you're familiar with the references, we could do it today. Anna, what do those involve?
Mr. Chairman, there's two other deferrals in statute. One's regarding drug possession and one's regarding domestic battery. I was just wondering if we wanted to include those along with the reference to 713-301.
Go ahead, Dan. What do you think about that?
Yeah, Mr. Chair, I would prefer, if you don't mind, if we wait. This is new to me, and I'd like to run this by our State Court Administrator or Wyoming Judicial Council and get their thoughts before I opine on behalf of the judiciary, if you're okay with that.
No, and that would be fine. We'll have adequate time. Judiciary will have time in the future as we consider that. So that's not a problem. Thank you for that input. Anything further you'd like to tell us about?
Yeah, just Mr. Chair.
Mr. Chairman, Mr. Chairman, might I just suggest we take the vote and then we listen to some other considerations that we have maybe on treatment quarters that applies to the diversion things that we're working on that we might consider either into this bill or perhaps even a separate bill. But let's take this vote first.
Very good. That in mind, committee, let's go ahead and take a vote on this bill. Roll call.
Mr. Chairman, this is a roll call vote for 25 LSO 29 treatment court amendments as amended. Senator Barlow,
Excused.
Senator Nethercott,
Excused.
Speaker Summers,
Excused.
Representative Swanitzer,
Excused.
Director Johansson,
Aye.
Director Schmidt,
Aye.
Director Shannon,
Aye.
Mr. Brown,
Aye.
Co-Chairman Larson,
Aye.
Chairman Baldwin.
Aye.
Mr. Chairman, we have 6 ayes, 4 excused.
Very good. That we will pass it. The other chairman and I will discuss that, and it'll probably go to judiciary, but we'll discuss that with the chair of judiciary. Very good. Let's go back to the mysterious man who's behind our heads. Sir, thoughts?
Thank you, Mr. Chairman. As we've reviewed these amendments to the Court Supervised Treatment Programs Act, we can't help but wonder if now would be an appropriate time to expand the act to include our behavioral health diversion tracks, to include these programs that are similar to what we've started in Gillette. I don't think a statutory expansion is strictly necessary. In Campbell County, we got that program off the ground based on cooperative agreements and really based on the agreement of the prosecutor in exercising his discretion to agree to hold charges in abeyance pending completion of the diversion court program. So it wouldn't be strictly necessary, but while not strictly necessary, we do see some immediate benefits to perhaps incorporating mental health diversion court tracks into the CST Act. And one benefit we see is that the legislation would give diversion tracks an even greater level of legitimacy and formality. This legislative blessing may help as we try to scale these programs statewide. And then another benefit we see is that it would allow us to use this existing statute and framework we have for overseeing and funding these types of efforts. So we don't have any specific amendments to propose today. We really just want to raise the idea and gauge the temperature of the task force. And if this is something the task force is interested in and would like to see some sort of bill draft, we'd be happy to bring our knowledge of and experience with the diversion court and work with LSO staff to help prepare amendments that would again incorporate mental health diversion tracks into the existing CST statute while we're doing work on it anyways.
Mr. Chairman.
So Ben and Anna, both, I think that's the conversation we've been having over the last couple of years as we look at this diversion project, what statutory changes are warranted and we need to get into place. And so I think that the timing is fine. And might I just suggest, Mr. Chairman, that we have the courts maybe work with Anna on a draft of how that would look. And I would look at it, Anna, but I'm not afraid to keep this bill separate from a new draft and let them move independently. And, you know, as we've done, but if you feel that it's just minor enough that it could fit in that, we could, well, we've passed this bill.
Mr. Chairman, I would say let's do it as a separate.
Yeah.
And then if there's a decision by judiciary that they want to create one of those amendments and put it into this bill, that would be fine. But I think we ought to keep them separate.
There we go.
Mr. Chairman.
Yes.
Just maybe one friendly suggestion there. I totally agree with Mr. Birmingham on, you know, the value and benefit of incorporating diversion programs into statute. Would just suggest, again, in a friendly way, permissive language at this stage of the game, as opposed to, you know, required or shall, would probably be best, just because it leaves open administrative flexibility for those types of programs, since we're so early in the development of the Campbell County diversion program.
Okay, that was very friendly and we agree. Okay. Okay. Thank you very much. Anything further, or joke for the day or anything you have for us?
I'm afraid not, Mr. Chair, but thanks for your time.
Ben, it's a great day in Kimmer when you're missing it.
I apologize. I could not be there.
It's so nice outside.
We'll enjoy it for you.
Great.
Thanks, Ben.
Thank you.
Okay, committee, let's move on. Let's see, Department of Family Services confidentiality amendments.
Mr. Chairman?
Yes, sir.
So Anna, if you wouldn't, that's right. So Lucas, if you wouldn't mind, I just want to recap again. We adopted some amendments last time. You've incorporated them, but there was some discussion on maybe to improve that. And I think you worked with Director Schmidt to put together an amendment. And so I don't know, Director Schmidt, whether it's you or Lucas, why don't you explain the amendment to us, and then Director Schmidt, would you explain the rationale behind it?
Absolutely, Mr. Chairman, Mr. Co-Chairman. Yes, this is 25 LSO-0004. This is version 6. It's the one that has been amended. It removed the penalty provision that I had put into the bill, and then it limited the conforming amendments to just those that were recommended by DFS. And just the final amendment was to split the effective date, which I have done. Just on the bill draft itself to start with, I did just want to mention, it just was based on some discussion at the May 24th meeting in Cheyenne. I've included a staff comment on page 8 of the bill, whether or not the task force would want to consider including a requirement for DFS to report to the Joint Labor, Health, and Social Services Committee on the types of data that are shared and any safeguards that have been implemented to protect personal data. And so that's just for your consideration. But that's just kind of a quick hit on the bill draft that we discussed at the last meeting. And then, just this week, I finished up a proposed amendment to the bill draft. And really what this amendment would do, and it should, hopefully everyone has a copy of it, would be to just adjust the purposes of the bill draft. So kind of turning back to page 2 of the bill draft, where it discusses the new duty that's being created for the director of DFS, where it's review the effectiveness and impact of programs and services, which shall include sharing data to the extent permitted by federal law for the purposes of, and it changes it from all that language that is in there to essentially say for the purposes of referrals, provision of services, and participation in bona fide research. And then there's then the second kind of half of that amendment is just making the conforming changes to Wyoming statutes 14.6.604A6 that's included in the bill. I would just note, during discussions with Director Schmidt, it was discussed to remove the language of notwithstanding any other provision of state law regarding confidentiality. And so this amendment would do that. And I know it was discussed in Cheyenne about not necessarily wanting to limit it to the scope of the particular statutes that are being changed, but I did include that in this amendment just to kind of be able to show you what it would look like. Just because I think there's some thought to, if you don't say that we're notwithstanding confidential information, then that might create some confusion, or at least the question of whether the Department of Family Services can share data that would be considered confidential if you don't provide that that's allowed specifically in statute. If you leave it to just say the director shall review the effectiveness and impact of programs. So just a couple notes, and I'm happy to take any questions or try and provide further explanation.
Any questions before we turn to Director Schmidt?
Can
Go
I, Mr. Chairman, so would you read to us how it would read now, that section X, please?
Absolutely. Mr. Chairman, Co-Chairman Larson, it would read, so Wyoming Statute 92-2104A10 would now read, notwithstanding any confidentiality requirements of Wyoming Statute 14.3.214A, 14.6.203G, 14.6.306, 14.6.437A, 14.6.604A, 35.2108, and 42.2.111A, review the effectiveness and impact of programs and services, which shall include sharing data to the extent permitted by federal law for the purpose of referrals, provision of services, and participation in bona fide research.
Very good. Director Schmidt.
Okay, thank you, Mr. Chairman. I wanted to draw your attention to the handout that we provided. This was a summary of responses to the many questions that were asked in the May 24th task force meeting. And I won't go through this document. I think it's important reference material. But essentially, after listening to the debate last time and having a lot more conversation within our own staff, and then some other conversations with members of the task force, it became apparent that this was just a little too wieldy and a little too expansive. And so in the conversation then with the LSO, trying to really pare it down and say exactly what is it that we want. We want referrals. We want to be able to make referrals. We want to be able to provide services through those referrals. And then we also want to evaluate our programs. Something to point out specifically, and really the core of this request comes from a particular statute in our Child Protective Services statute that right now limits us from sharing any information about a case, including if it was reported. So it is so confining that any type of data discussion, and in fact, really probably shouldn't be reproduced under the current statute. What allows us to provide some data is federal law allows it with children in care. But the majority of the cases that we're involved in involve children that are placed at home and are not in foster care. So the very restrictive nature of that statute is really what has brought this conversation to you. We tried to go through and list all of the various projects that we are interested in or that we want to participate in, where the current statute would not allow it. And that's part of the document that we included. So for example, with SLEDs, We would not be able to share any data with SLEDS under the current statute because we can't share anything about that particular report. So our participation in SLEDS and including any data about our children who come, our families who come to us because of a protective services reason, a CHINS reason, or a delinquency reason would then not be able to be shared. One of the conversations from the last task force was, would it be better to delineate in statute all of the different types of projects where we would want to share information and tackling it within each of the confidentiality provisions that way? We could do that. It will become very cumbersome and very confusing. One of the reasons for that is because each of the statutes are written just a little bit differently from each other. So the language around those particular confidentiality statutes would have to be tailored. So it goes back to then just the general authority of the director and giving the ability to the director to say, this is bona fide research, or this is specifically for the purpose of referral, that we can allow that data. I think where we can tackle those issues about individual projects is through rules. It would be very easy for us to promulgate emergency rules around a particular type of project where it says, this is the data we want to share, here are the protections around the data, and then it could go through that process. So that's really it in a nutshell. It's an attempt to try to take out some of the long laundry list of all the things and really just narrow it down to what is it that we exactly need it for. And that's referral of services, provision of services, and then evaluation of the programs that we manage and operate.
Questions for Director? See none? Very good. Any public comment on this before we move forward? I don't see anybody standing up to you. No. So what I would ask is let's first move the bill.
Move the bill.
Moved, second. I believe the second came from the same place, from Director Giants. Okay, committee, we have bill before us and we have an amendment before us. Anybody like to move the amendment?
Mr. Chairman, I move the amendment.
Second.
Okay, we got a move and a second by Chairman Larson. Comments, committee, discussion.
Chairman, I'd only say that I think that there was some angst by some of the task force members last time, particularly on notwithstanding and then wanting some further information. I think that this amendment really went a long ways to cover that. I think Director Johansson was going.
Mr. Chairman.
Go ahead, Director.
Maybe a question for Lucas. Do you know off the top of your head, just the title of 42-111? What is that referencing?
Give me 1 second. I should know, but I don't remember. I can pull it up right now.
I'm just curious if it's in Department of Health and Medicaid world. I don't think so, but I don't have the reference off the top of my head.
42 what?
42-111A.
Yeah. Mr. Chairman, Director Johansson, it's under the Public Assistance and Social Services chapter within the Title 42 welfare, and it is just discussing administrative and judicial review for applications.
Okay, very good. Thank you, Mr. Chairman.
Very good. Further discussion, questions, committee, before we vote?
Question on the amendment?
Question on the amendment. All those in favor of the amendment, please say aye.
Aye.
All opposed, say no.
Mr. Chairman.
That amendment passes. Yes, sir, Mr. Chairman.
Mr. Chairman, on page 8, I would like to add in section 3 that was suggested by LSO to require reporting component to the Joint Labor and Social Services interim committees, and then make adjustments to the existing section 3 and whatever is necessary.
Okay. Got that. Lucas, go ahead.
And Mr. Chairman, Co-Chairman Larson, my apologies. I would just say, I kind of left at the very end of the section 3 language that requires the report. It's requiring that report not later than, it can be October 1st or whatever you would like it to be. But I just wanted to leave that to the task force determination.
Madam Director, when's a good time to have that? We need probably like October-ish so that we can get into their interim committees.
Mr. Director.
Mr. Chairman, Mr. Co-Chairman, yeah, October 1st is fine. I think that's typically the date we have reports due to you all, so it fits in line with what's pretty standard.
That's generally a good time, because that's usually our final committee meeting.
Mr. Chairman, will this bill be referred to judiciary or joint labor?
We've not made that decision.
The only comment I have on that is with the staff comment on page 8, which committee is most relevant for this? And I would defer to Director Schmidt on that if it is, labor, health, social services, or judiciary, given the nature of the text of the bill. To me, it's kind of one or the other.
Yeah, fair enough.
Okay, go ahead,
Warren?
Director.
Mr. Chairman, to Dr. Johansson's question, most typically we appear before joint judiciary. It's very infrequently that we appear before labor because Title 14 involves the courts and the large to large.
I think that's a
extent.
friendly amendment.
Okay. So we got that all down. Committee, any questions, additions to that amendment?
No, that was an amendment that I adopted into the amendment.
An amended amendment. Okay, committee, you've heard the amendment. All those in favor of this amendment, please say aye.
Aye.
Opposed, say no.
Move
That
the bill.
that amendment is passed.
Question on the bill.
No further amendments. Question on the bill. Roll call.
Mr. Chairman, this is a roll call vote for 25 LSO 4, Department of Family Services confidentiality amendments as amended. Senator Barlow,
Excused,
Senator Nethercutt,
excused,
Speaker Summers,
excused,
Representative Zwanitzer,
excused,
Director Johansson,
Aye.
Director Schmidt,
Aye.
Director Shannon, Mr. Brown,
Aye.
Co-Chairman Larson,
Aye.
Chairman Baldwin.
aye.
Mr. Chairman, we have 6 ayes, 4 excused.
Very good. That bill will be passed on to judiciary. Okay, committee, I just lost my agenda. Was that the only bill drafts we had?
Yes. The only
Okay.
two.
Any directives for the LSO committee?
Mr. Chairman,
Go ahead, sir.
Let's see. So we talked about getting the essential services on. Go ahead, Luke.
Mr. Chairman, Mr. Co-Chairman, on the agenda, we did just have an update on the confidentiality misdemeanor bill, if you'd like me to provide that information to you.
Okay, please.
Please do.
Organize here. Mr. Chairman, at the last meeting, it was discussed to create a misdemeanor within Title VI, the criminal statutes, specifically related to the unlawful disclosure of confidential information. And so I spent a little bit of time researching into this, and I just think it could be a fairly complicated bill draft. Not that we couldn't do it, but just considering the short time frame between the last meeting and this meeting, I wasn't quite able to get it put together. Just for some general information, within Wyoming statute, there are, I believe, 498 references to confidential or confidentiality. And that doesn't necessarily include other references that may fall into this category, I believe, as the task force may wish to consider, such as patient or other identifiable records that are to be kept, confidential or, that are not to be disclosed. Some of that language is different in statute. And so I did look, primarily I kind of started looking at some of the titles that we were talking about, like Title 14, Title 35. And as Director Schmidt had mentioned when we were talking about the last bill draft, so a lot of this language is not consistent. First, just in terms of how it's actually mentioned in a few sections in Title 14, it's fairly similar that all records, reports, and case planning recommendations of a multidisciplinary team are to be confidential. That's fairly consistent. But then, under 146604, which is also amended in the bill draft we just discussed, they use language such as information in the juvenile justice information system shall be preserved in a manner to avoid identification of an individual subject. And so, just it is those questions, just trying to make sure we're finding all of those different places that would maybe be affected by this. And I would also just note that there is a difference in penalties throughout statute. The most common version of a misdemeanor penalty in the criminal statutes in Title VI is a misdemeanor punishable by imprisonment for not more than 6 months, a fine of not more than $750, or both. But then such as in, as was discussed at the last meeting, there's a lot of times that a penalty provision is added on to a specific statute. And one for the reports, investigations of child abuse or neglect. If you're found guilty of violating confidentiality there, you can be guilty of a misdemeanor and it's a $500 fine and in 6 months imprisonment. For predisposition studies and reports in like a juvenile case, for that fine it's just a fine only offense of $500. But then if you go into Title 35, when you're discussing communicable diseases, that can be different where it's 6 months, $1,000 fine. And then there's even considerations such as, the confidentiality of genetic testing, which is a fine of $1,000 or 1 year imprisonment. So it just would be that question of what would be the task force recommendation for providing a penalty, if you'd like it to be the same, and just generally the scope of the bill, because there are just a lot of different places where it may just say these records are confidential without a penalty. And I think creating a general penalty within the criminal statutes may encompass all of those particular statutes that didn't previously have a penalty. So there's just some things to consider in for this bill draft, if you'd like to provide any other direction.
Mr. Chairman, go ahead. I know that we really give you a short time frame to get to this, and so we're fine. I just think that Senator Nethercott, whose suggestion it was that we move forward with this in this concept, in this idea, is, I would suggest, is our resource there, and would suggest that we just try to coordinate with her and take the pulse of how that should move forward with her, and then kind of get back, and we'll be in touch with her as well and try to get some guidance.
Yeah, and I would say if we be in touch with her, and we will as well, that we move forward with the bill draft and then discuss it in Torrington.
Mr. Chairman, Mr. Co-Chairman, absolutely. I will continue to reach out to Senator Nethercott and try and have that discussion with her and try and get something. We'll get something ready to go for Torrington. Perfect. Yes.
Perfect. Okay, committee. Any directives for LSO? Anything we've talked about they need to do besides the last slide?
Mr. Chairman, I'd like to try and see if you would reach out to Miss Brandt in the governor's office, who is having some direct conversations with BAR and got that presentation for joint education today. If there's any way that we could get them in person or on remotely for the Torrington meeting, and then I'd like to further the conversation and get honed down on the cost that we would anticipate, because I think that's really going to drive our ability to even pass it out of the task force, let alone get it approved. I think everybody agrees with what the program does, but when you can, the comparison on cost versus what we have in like our mental health, I think is a valid deal. I think Mr. Chairman, I think we're really honing down and I like the direction we're going, but I think we need to understand a more accurate number. It doesn't have to be the final number, but I think, is this really, so maybe that's you, Dustin, but if we could have something more for that. Then I think that we need to be prepared, task force members, those of you that are here, to be ready to vote on support of AWARE and that funding. Whether we like that, to have some further discussion on any shortfalls we see in the program or the funding. Understanding again that I think that the vote on AWARE would be one thing, realizing that would be ongoing funding. If we don't include BAR, it would leave a gap in that, but there are other providers. If we don't like where BAR comes in, we could look at other alternatives, but then we would include BAR, I think, as a second recommendation to JEC. And they may move forward. They may move forward without us and say, we don't need you, which they don't need our blessings. But I'd like to learn a little bit more. And then, of course, that conversation we just had on is all I had. And then we can get is tomorrow Friday?
Yes.
Tomorrow or Monday, Will you guys be traveling tomorrow? Maybe we try and reach out Monday and set an agenda for August a little bit and start. Do you guys have something Monday? Monday or Tuesday? Tuesday the rest of the week gets a little wonky for me.
I think I'm good until Wednesday. Yeah, very good. The only other thing that came to mind, and it's just an informal thing, and that would be Miss Osmond that was gonna get us information on the grant monies, and they will have that received by then, if we can get that number from her. Even just via email or a memo from her, so we know what it is. She didn't necessarily have to appear. Okay, committee members.
Mr. Chairman,
Yes, sir.
big thanks to LSO staff, all four of you. Thanks for everything today.
Yeah, you guys are awesome. And I would tell you, you're kind of here late today if you want to stay. There's lots of stuff coming up in Kimmer in the next 2 days. This is the fish fossil capital of the world. And we're coming up tomorrow. You see them setting up next door is the Rock and Jim show. They're setting up for that now. And tomorrow starts Fossil Fest.
I love fossils.
It's a good time. And if you ever have a chance, if you want to come back, not in this capacity, but come back and dig fossils and look for fossils, it's very cool. Very cool. If you've never done it, it is cool. It's actually very hot. But it is fun. We have just a tremendous, even Bill Gates looked for fossils and split some fossils. So yeah, it's great fun. So welcome. Thank you for coming to Kimmer, and always welcome back here. You can come visit me in my house. Okay, with that committee, we're gonna adjourn this meeting. We'll see you in Torrington.
Thank you, Chairman.